Clinical Lead for Therapeutic Endoscopy and Endoscopic Resection at the Cleveland Clinic, Abu Dhabi. It gives me great pleasure to introduce our first speaker, Associate Professor Moin Kashab. Dr. Kashab is well known to us. He's a world-renowned expert in advanced and innovative endoscopic techniques. He currently holds the director position for therapeutic endoscopy and endoscopic training at the Johns Hopkins University School in Medicine in Baltimore in the US. Dr. Kashab is also the course director of the High-Tech Hopkins International Therapeutic Endoscopy course. He has participated as faculty in numerous live international endoscopy symposiums and conferences. He's published extensively in the field of therapeutic endoscopy and innovative endoscopic techniques in peer-reviewed journals. He also sits on multiple international editorial boards and advisory committees and groups. Please join me in welcoming Dr. Kashab. Over to you, Moin.
Thank you, Omar. It's a pleasure to be here. Let me try to share my screen here.
Good morning, everyone. I'm Dr. Yogesh Shastri, HOD Gastroenterology at NMC Specialty Abu Dhabi, UAE. I cordially welcome you. Delegates all over the world. To give you a brief about Asian US Group, it is a not-for-profit organization based in Singapore and promotes EUS in the Asia-Pacific region. It conducts interactive courses and workshops to facilitate advanced learning of EUS. This year, due to global restriction on travel and social gathering, we have planned a web-based interactive hybrid conference. A brief introduction about our department. We have a comprehensive setup of gastroenterology services in which we provide diagnostic and therapeutic advanced services like US, ERCP, cholangioscopies, endoscopic dissections, GI motility, to name a few. We were the first hospital in the private sector to provide endoscopic ultrasound services in Abu Dhabi, and we have performed more than 850 US cases till now. This is our team of gastroenterologists at Abu Dhabi, and this is our extended family at work. Before we start this year's conference, I'll give you a just quick recap for the people who are attending it for the first time. This is the consecutive 6th year we are having this meeting. Our first international conference was held in 2016. Since then, we are hosting this conference annually with an ever-growing audience and active participation from everyone. In the last 5 years, we have had galaxies of stars in our meeting visit Abu Dhabi from all over the world, and which give us the opportunity to interact closely with them and learn so many new things from them. Today's full day agenda, we have in store treasure of GI feeds with topics ranging from Barrett's esophagus, third space, endoscopy, cholangioscopy, artificial intelligence, and future of endoscopy by stalwarts of gastroenterology all over the world. Today, we are honored to have possibly the best experts to give us tips and tricks to learn gastroenterology and GI endoscopy. Another highlight of today's meeting is a live transmission from two of the premier gastroenterology institutes in the world, the Chinese University of Hong Kong, which is headed by Dr. and from SL Raheja Hospital, Mumbai, led by Dr. Vinadir. Without further delay, I'll hand over the stage to our distinguished chairpersons. I would like to invite first Dr. Amar, who is a consultant gastroenterologist at Cleveland Clinic, Abu Dhabi. He has done most of his training in Australia, Japan, and UK.
I send it to 10 groups.
Include image enhanced endoscopy, high-quality colonoscopy and bowel cancer screening, and managing complex GI polyps. He also has authored chapters in textbook and research journal. The second distinguished chairperson is Dr. Atul Chawla, who is working as head of the Department Gastroenterology at Meteor Hospital, Abu Dhabi. He has extensive experience in the field of gastroenterology, including endoscopic ultrasound and therapeutic endoscopy. With this, I request moderators to take over. Hope you will have a good learning day today. Thank you.
Okay, apologies for taking over and hijacking the meeting. So going back again, quickly again, Professor Moin Kashab, as we said, he's a world-renowned speaker, well known to everyone. He's the advanced expert in innovative endoscopic techniques and currently holds a director position for therapeutic endoscopy and endoscopic training at the Johns Hopkins University School of Medicine. He's also the course director of the high-tech Hopkins International Therapeutic Endoscopy course and sits on multiple societies and groups and advisory committees and has published extensively in the field of innovative and therapeutic endoscopy. Please join me again in welcoming Dr. Kashab. Over to you again, Moin. Thank you.
Thank you, Omar. It's a pleasure to be here. Please confirm that you can see my slides.
Yes, we can.
Okay, excellent. Hello, everyone. Thank you for inviting me. It's a pleasure to be here. First time I participate in your esteemed conference. And my topic today is on third space endoscopy. This is a big topic in 2020. So I will be focusing on peroral endoscopic myotomy from A to Z. So we'll cover POEM for achalasia, then POEM for gastroparesis or G-POEM, and then end with talking on Z-POEM or Zenker's peroral endoscopic myotomy. So let's start with esophageal POEM and the main indication, as everyone knows now, which is achalasia. This is a video on how we perform the procedure. This is the myotomy part. So after we tunneled and exposed the muscle, we use a specialized knife. Here in this case, we're using a triangular tip knife. And the goal is to cut the inner circular fibers and expose the outer longitudinal fibers. We prefer to conserve the outer longitudinal fibers just as a safety net to keep us away from mediastinal structures. Once we're close to the lower esophageal sphincter, we change the myotomy to a full thickness myotomy. Here, we're clearly seeing the outer longitudinal and the inner circular fibers, and we can selectively cut and very accurately cut the muscle. We extend it towards the LES and then extend the myotomy through the LES towards the gastric cardia, typically by about 2 to 3 centimeters. An adequate gastric myotomy is important. This is a study we recently published in Endoscopy International Open on 4 years outcome of POEM performed for achalasia. And we can see here consistently, even at 4 years, that the clinical success with POEM was in the 90s. So very excellent outcome results. Now this is POEM, anterior versus posterior. We know POEM can be performed using the anterior approach and also the posterior approach. So this is a randomized trial comparing both approaches. We published this trial in GIE a few months ago. And here, clinical success at 1 year, 90% versus 89%. So equivalent clinical success between both approaches, and also all reflux data was equivalent between both approaches. So the conclusion of this study was that anterior and posterior approaches were equivalent in terms of efficacy, safety, and reflux rates. How does POEM compare to other available techniques that we use routinely for the management of achalasia? So nowadays we have level 1 evidence to compare POEM to pneumatic dilation and POEM to Heller myotomy. This is a randomized trial published in JAMA a year ago comparing pneumatic dilation to POEM. And at 2 years, we can see here clinical success, 92% for POEM and 54% for pneumatic dilation. And the difference was statistically significant. What about how do we compare reflux data? So reflux esophagitis, 41% in the POEM group, 7% in the pneumatic dilation group. So significantly higher rate of reflux as expected with POEM. Most reflux was grade A and B. We have some C, grade C. We see D occasionally, but it's rare. So mostly low-grade esophagitis. So POEM is more efficacious than pneumatic dilation, but it's associated with increased rate of reflux. How does POEM compare to Heller myopathy? This is a major landmark study published in the New England Journal of Medicine. And at 2 years, clinical success, 83% in POEM group, and 81.7% in the Heller myopathy group, again, equivalent and not statistically different. How do the reflux rates compare between POEM to Heller myopathy? Mind you that Heller myopathy is performed here with toupet fundoplication. If we look at 3 months, there was significantly increased rate of esophagitis in the POEM group, but at 2 years, this difference between the two groups is closing, because what happens is that the fundoplication tends to loosen over time. So we see the gap with reflux rates diminishing between the groups over time. And if we look at objective acid reflux data at 2 years, they were pretty equivalent, 30% and 30% for abnormal pH studies at 2 years. The same way they combine, or surgeons combine to Heller with toupet, we thought also we can combine POEM with endoscopic fundoplication. This is just a feasibility study where we were able to perform same session POEM with TIF, or transoral incisionless fundoplication for patients with achalasia. This is still at a research status at this point, and we're still investigating the combination of these approaches. How safe is POEM? This is the largest study published on POEM. We published it a few years ago in the American Journal of Gastroenterology, more than 1,800 patients. The overall adverse event rate was 7.5%. 5.9% of the 7.5% were severe events, the vast majority mild or moderate. What kind of severe events we see? We see intra-procedural events and then some post-procedural events. These can be bleeding, cardiac arrhythmias, esophageal perforation, leaks, symptomatic pneumomodystinum, aspiration pneumonias, and empyema. These events are very rare. You see, out of more than 1,800 patients, we see here very few having these severe side effects. So we move now to the second part of the talk, which is gastric per oral endoscopic myotomy or endoscopic pyloromyotomy for the management of patients with refractory gastroparesis. Several endoscopic therapies have looked at were directed towards the pylorus as Botox injection. 2 randomized trials comparing Botox to sham were negative. So Botox was not superior to sham in patients with gastroparesis. But if you combine patients in both arms in both studies, the total number of patients was 55. So clearly underpowered studies. In our clinical practice, we do see some patients who respond significantly for Botox injection. Based on that, we published the study on transpyloric stenting for patients with refractory gastroparesis admitted to the hospital. This is by no means a treatment. This is temporizing these patients to help them get discharged from the patients. Basically, all this data points at a possible role of the pylorus and symptoms of gastroparesis. Based on this data, we thought of performing pyloromyotomy for gastroparesis, and this is the first patient or the first reported procedure in 2013. That patient continues to do well, and I'll show you how this procedure is done. few centimeters, about 5 centimeters proximal to the pylorus, submucosal injection, typically saline and methylene blue. We don't like to tunnel far away from the pylorus because there's no need for a long antral myotomy that can worsen gastroparesis. And also with the long tunnel, you can actually end up tunneling away from the pylorus. So important is to just keep your tunnel short. Same as we do with esophageal poem, a longitudinal incision, some submucosal dissection to introduce the scope and a cap into the submucosal space. And here we are in the submucosa. We'll move to step 2. 6 o'clock, we have the muscularis propria. We tunnel on the surface of the muscularis propria. Here we're using the triangular tip knife and spray coagulation current that makes the procedure go pretty fast. If we have large vessels, we can coagulate them with a coag grasper. Smaller vessels, we can treat with the knife itself until we reach the pylorus here, which is a distinct ring, muscular ring, and we see the duodenal mucosa running parallel to the pylorus ring. So now we move to the third step, which is the pyloromyotomy itself. I like to use an insulated tip knife to protect the duodenal mucosa, which is very close. Here we're using endocut Q current, and it's like skinning an onion, layer by layer, down to the serosa. So we intend to perform a full thickness myotomy. Delineation of muscle layers is harder here in the stomach because you also have the oblique muscle fibers. The ceramic tip, I believe, helps you understand when you're at the most outer layer of the muscle, because once you can't grab tissue with the ceramic tip, that indicates that you are either at the serosa or close to the serosa. So here we still have a little bit of muscle, so we continue to cut a little more. And these days we can also create another incision to the right of this incision and then snare the muscle in between to create a wider myotomy. That is a newer technique we have been following. At the end, we either close with clips or suturing. Initially, we used to suture. Now we just clip. Clipping here is a little harder than the esophagus, but once you get used to it, it's pretty feasible. Sometimes you need to use the 17-millimeter clips instead of the 11-millimeter clips. First multi-center study on GPOM published in 2017. 30 patients, different etiologies of gastroparesis, severe symptoms, 60% recurrent hospitalizations, and clinical success with significant improvement in symptoms in 86% of patients. Most patients had either normalization or improvement in their gastric emptying scan. Only 2 minor adverse events. GPOM is pretty safe and rarely you see major adverse events. This is a study from the Cleveland Clinic group, Cleveland Clinic, Ohio. The first 100 patients that had GPOM, and you see the gastroparesis cardinal symptom index decreased from 3.8 to 2.4, significant decrease. Here it's important to understand that this is different from esophageal poem, where most patients have either a minimal or no symptoms after poem performed for achalasia. Here expectation is that we're improving the symptoms a little bit with improving the quality of life of these patients, but the expectation is not complete resolution because the pylorus plays one part of the pathophysiology of gastroparesis, but the pathophysiology is very complex and there's no expectation for complete improvement. The gastric emptying improves here 39 minutes to 39% retention at 4 hours to 16% retention at 4 hours, and 33% normalization of gastric emptying. Does etiology of gastroparesis matter? Here in this study from Emory, they showed that diabetic gastroparesis and non-diabetic gastroparesis patients respond equivalently to G-POEM. This is a meta-analysis we put together, all the studies on G-POEM, about 82% clinical success, minus 2-point decrease in the cardinal symptom index, pretty significant when you have decreased by 2 points. Improve in gastric emptying by 23%. So G-POEM, we think it plays a role, still an evolving field, and results haven't been as impressive as esophageal POEM, but clearly there is a role. The main question these days is to identify the subset of patients with pylorospasm that will respond to gastroparesis, and we can talk more about it later. The last part of the study is on Zenkers or Z-POEM. We know that the way we treat Zenkers, the endoscopic management, is based on septotomy. So we have the diverticulum and we have an esophageal lumen. We don't get rid of the diverticulum, which is also here. We just cut the septum, and this transform this structure to this structure where there's no partition between the diverticulum and the esophagus, and thus the diverticulum readily empties into the esophagus and eliminates symptoms of halitosis, regurgitation, dysphagia, etc. This is a standard septotomy that we use. This is not the Z-POEM technique. This is a standard technique here using a scissor-type knife. Some of us put an NG in the esophagus to try to protect the opposite wall. In the US, we do not have a diverticuloscope, so we don't use it. Actually, most physicians outside the US also do not use the diverticuloscope. Here we see that this patient had prior staple diverticulotomy, still has a huge septum, huge recurrent septum. Although this procedure is relatively easy and it's done worldwide, it's hard to understand or delineate the bottom of the septum. So we end up leaving some septum to avoid perforation, and that's believed to be the cause of recurrent symptom afterwards. This is a study from a very experienced group, Jack DeViers, and over 5 years, 23% recurrence rate, even in best hands for this technique. So the idea is to perform a procedure where we can completely cut the septum, and we know septum is a muscle, and we can completely expose the muscle using submucosal endoscopy. Here you see that I'm starting to tunnel proximal to the septum. So this is how we started doing the technique. And then we tunnel towards the septum, and then to the right and left of the septum. So here we're tunneling on the diverticulum side, and now we tunnel on the esophageal side for complete exposure of the septum. Once the septum is completely exposed, like we see here, we go ahead and perform a septotomy. So the advantage of this technique is complete exposure. So we can cut the entire septum and extend the myotomy by a couple of centimeters into the upper esophagus. And that ensures complete septotomy. And we believe that is possibly correlated with less recurrence. There's no science to it right now. We are preparing a randomized trial. So the evidence is yet to come, but the initial results are very promising. Here, the problem with this technique is that we tunnel very proximal in the hypopharynx. So closure is difficult because there isn't much space. So that brings us to the most updated technique, which is tunneling on top of the septum. So over the septum itself, we create a bleb. This simple saline and methylene blue. And then an incision, about a centimeter incision, using endocut Q current. So we're right there at the septum, so no tunneling towards the septum. And so the septum is right there, so pretty easy. And then we tunnel on both sides. So complete exposure of the septum, then complete cutting of the septum, extension of the myotomy towards the upper esophagus, followed by closure of the mucosal entry site. Here, since we're tunneling over the septum, so a little below the hypopharynx, there's more space for closure. So closure actually becomes very easy since you have more space. We like to use clips with short stalks to avoid foreign body sensation. So here is the mucosal entry. This is the SB knife. Works really well for Zenkers, whether you're doing a standard septotomy or a Z-poem. And this is these are the clips with short stalks that we talked about. And closure is pretty straightforward, typically 3-4 clips, and then you're done. We published this first trial on Z-poem, 75 patients, clinical success 92%. Procedure dysphagia score went down from 1.96 to 0.25. Again, initial results, very promising. We need long-term data to really check if the recurrence rate is lower or not. And as I mentioned, a randomized trial is being prepared. So to conclude, third space endoscopy is pretty exciting field with a lot of applications and exciting results. POEM is safe and effective in the management of achalasia and gastroparesis. Severe adverse events are uncommon but may occur. Z-POEM is a promising technique for the management of symptomatic Zenker's diverticular. Thank you for your attention.
Thank you, Moin. That was a great overview of third space. I'd like to ask you about stir technique, submucosal tunneling endoscopic resection. For gastric cysts, what's your size cutoff for deciding whether you're going to go endoscopically or laparoscopically, knowing that I guess sometimes bigger ones are hard to get and extubate out of the patient?
Yeah. So that's a very good question. So the most stirs that we perform are in the esophagus. In the stomach, it's harder to perform a stir unless it's like in the antrum. But most gysts are in the gastric fundus or cardia, and we end up doing full thickness resections. But same thing, I've reported on a stir for a 10 centimeter leiomyoma in the esophagus. Very hard to get out, but you can. So, but consistently taking out a gyst en bloc, I will say around 4 centimeter. 5 centimeter is pushing it. 4 centimeter, you can get it through the LES, through the UAS, and outside the patient en bloc. 4 or 5 centimeter, probably that's a reliable. More than that, we've done also a laparoscopic assisted where we handed it to the surgeon to remove it laparoscopically. But if you want a pure transoral approach, that probably will be the limit for a consistent results.
Sure. One more question. I guess it's a growing field, and it's really exciting to see how endoscopic innovation is really solving a lot of issues now. But for those, I guess, is there any advice from you on how people should really take this on board if they want to train? And is there any guidelines on how would you call a center of excellence, I guess, for endoscopic poems and all of that?
Yeah, so we and many others, including some here on the panel, I see Amol Bapai is here, who perform this for a living. We've trained people. we believe in dedicated fellowships for third space endoscopy. I think we have enough volume, enough procedures to have a dedicated fellowship. We don't have that yet, but I believe we should. But to be trained in these procedures fully, I think starting in an animal model is great. Watching a lot of videos, reading the literature, being in conferences like this, and this should be followed, of course, by extensive hands-on training. The endoscopist should be an interventional endoscopist, or the surgeon should be an interventional endoscopist, because you got to deal with leaks and perforations and bleedings, and you need to use fluoroscopy and put stents, etc. So it's not just being able to dissect the muscle. It's also the downstream things that you have to deal with as well. But I believe we're getting to dedicated fellowship. It's gonna happen the next 5 years. There are some fellowships around, like Haro Inouye has a dedicated year of fellowship. But in the US, we don't have that dedicated year, but it's coming.
Thank you. Yeah, we experienced the same issue. I mean, I trained in Australia, and there's probably 1 or 2 centers that we just try and get as much volume and experience doing EMRs first, and then proceeding to ESDs and all these advanced techniques. But it's not easy. But thank you. I think
yes, it was just since you mentioned Australia, where the Payal Saxena, you know her. I trained her in poem, and she's a superstar and doing a lot of poems in Australia. So that tells you, training is important and it's available.
Yes, I agree. I know Payal very well, and she's the first who's had a dedicated training fellowship, and your input on her really has benefited a lot of people, and we appreciate that. And thank you for all your contributions. Thank you. Okay, so I'll hand over to the next chair to introduce the next speaker.
Hi. Morning. Am I on?
Yes.
Our next topic is on artificial intelligence diagnosis and endoscopy and its impact on cancer management. And I have the pleasure to introduce, he's well known enough, Dr. Pratik Sharma. He completed his internal medicine residency at the Medical College of Wisconsin in Milwaukee, and his gastroenterology fellowship from University of Arizona. Dr. Sharma has been in the forefront in improving diagnosis and management of GI disease and cancers, specifically in advanced imaging and endoscopy treatments. He's a well-known physician, teacher, and educator. Dr. Sharma has more than 400 publications, and in leading journals like NEJM, Annals of Internal Medicine, GI Endoscopy, Gastroenterology, and American Journal of Gastroenterology. He is the currently governing board member of American Society of GI Endoscopy. Also, he has hosted a global artificial intelligence GI endoscopy summit and has been named as the chairman of American Society of Gastroenterology endoscopy task force for the subject. So I'll hand the topic over to Dr. Pratik Sharma.
Hi, Atul, Yogesh, thank you. And I think we can start it.
Jason, can you play the video?
Hope to be with. Hi, this is Pratik Sharma from Kansas City, and it's my pleasure and honor to join all of you during the 6th International Gastroenterology and Therapeutic Endoscopy course, which has been hosted over the years by Dr. Yogesh Shastri. So Yogesh, thanks very much for this kind invitation, and I hope to be with. Start off by discussing some basic definitions about what is artificial intelligence. As a broad definition, artificial intelligence is a branch of science that performs tasks requiring human intelligence. We also hear about this term machine learning, which is the ability of computers to perform tasks by analyzing the data, and they are able to generate decision-making algorithms. And finally, deep learning is a computation of multiple layer neural networks, which is a subpart of machine learning in itself. So let's just look at this in a cartoon format. And you can see here on the top is machine learning. So for everything, you need an input, and the computer gives the output. Whereas in the lower part of the cartoon, you can see how deep learning works. So you can see that in both cases, we are trying, or the computer is trying to determine whether the output is a car versus no car, with the input of multiple images of the car as well as the features fed in. And so these are some basic definitions and concepts that we need to be aware of when talking about artificial intelligence. We'll also look at different algorithms used for machine learning in endoscopy. It starts off by using the external standard, and a training set is developed, which is then fed in and leads to the development of algorithms. Then you have a test set, which is used to assess the accuracy of the algorithms, and the training set should be different than the test set in order to assess the accuracy of the algorithms. And then finally, you do want further and additional training so that you can revise and then have a near final algorithm which is ready for deployment. So how can artificial intelligence improve healthcare, and specifically gastroenterology? These are some of the potentials that we have. It can improve our speed, meaning reduce delay in diagnosis. Computers can lead to automation of tedious and repetitive tasks. It can expand access to services, so for example, mass screening, and it can help us get faster and consistent diagnosis for diseases. Why are we interested in this right now? First of all, we need to understand that a lot of money is spent in the United States on healthcare, supposed to be close to $4 trillion. So AI can help us both on the clinical side, but also the thing we forget is on the administrative side. On the clinical side, it can help us with imaging, patient intake, remote health, inpatient hospital care, precision medicine, but also other tasks such as day-to-day operations, the data infrastructure, medical documentation. All of this can be helped with the use of artificial intelligence as well. And of course, it's no surprise that there has been, in a way, an epidemic of publications in artificial intelligence over the last decade or so. Now, if we go specifically to image recognition, there are a number of uses which have already taken place in other fields, such as in diabetic retinopathy, in mammography, as well as the use in autosegmentation in radiation oncology. So we are a little bit behind the field as compared to the other areas of medicine. This is something which puts this all in perspective about artificial intelligence in the detection and the treatment of an acute stroke. So imagine a patient going through a scanner for a suspected stroke. There is a large vessel occlusion, which is seen on the scan, and this is sent to the physician on their smartphone, in which the physician can look at the images and can confirm that there is a large vessel occlusion, and he or she can directly call the referring physician, the emergency room, and the patient can be taken in for acute thrombolysis therapy or whatever the treatment may be. And so it has been shown that it can lead to faster treatment, and this is something which has been approved. So you can see the concept of how artificial intelligence can impact the diagnosis and treatment. So now let's focus our attention to artificial intelligence in gastroenterology and specifically endoscopy. We can lead to polyp recognition, characterization, and abnormal areas within the lesion, as well as the extent of the lesion. So in a way, looking at both diagnosis as well as treatment. So when we look at GI cancers, we want to see how can AI help in the detection of GI neoplasia, and then that leads to endoscopic treatment. So we have evidence of how GI of artificial intelligence works in both these fields. This is an example of the use of artificial intelligence in squamous cell cancer of the esophagus. And you can see that on narrowband imaging, there is an abnormal area with a bounding box around that. And in this study, they looked at the sensitivity, specificity, and the overall accuracy of an AI system compared to a group of experts in endoscopy, specifically squamous cell cancer. And you can see that the sensitivity and the negative predictive value of AI was as good, if not better, as compared to those of experts in the field looking at similar videos of patients with squamous cell cancer of the esophagus. This is, again, looking at esophageal applications, is in patients with Barrett's esophagus and esophageal adenocarcinoma. This is, you can see an endoscopy in a patient with Barrett's esophagus, and right off the bat, you can see an abnormal area, and the device here is giving you also the prediction of what the probability is of this being a dysplastic or a neoplastic area as you move from white light to near focus magnification with virtual chromoendoscopy. So these are tools available which can give you real time while performing upper endoscopy in this situation in patients with Barrett's esophagus. There are different machines which are being tested. This is from the German group, which uses a slightly different monitor. On the left-hand side, it gives you the preview mode. On the right-hand side is the dense predictor. And you can see that almost a heat map is generated when the lesion comes into view. So it gives you the area of abnormality, and on the bottom, the bar gives you the probability of this being neoplastic or cancerous. Here you can see the regular patterns. So it says that the predicted histology is non-dysplastic Barrett's esophagus, and it also tells you that there was zero probability. So how confident the computer is in making that call or assigning that degree of risk to a particular lesion. Here is a lesion right above the gastroesophageal junction, and here the AI predicted cancer probability is 99%. So you can see that now we have assistance from machines telling us not only where the lesion is, but also what the risk prediction is in that particular lesion, which is seen on endoscopy. So what's the evidence that this works in patients with Barrett's esophagus? This is a recent publication from Gastrointestinal Endoscopy, and the evidence is there, but you can see that there are limited data at this time. So 6 studies with 560 images and showing a very good sensitivity and specificity and an area under the curve of 96%. And they analyze the algorithms which were based on CNN studies as well as non-CNN algorithms, showing similar results between these two types of studies. So there is evidence, at least preliminary evidence, I would say, that artificial intelligence for the detection of neoplastic lesions in Barrett's esophagus works. Similarly, if we look at other areas within the GI tract and other modalities, this is AI-assisted endocytoscopy, which is a way of looking at severe magnification, almost up to 1000x. And again, the same thing, that it looks at the cells, but not only is it showing you the different pit patterns on magnification, but it's also telling you that you should try to biopsy this lesion, or this is not a good sample. And if you should biopsy the lesion, it's because it's a 99% chance that this is an area of invasive cancer in this situation. Moving into gastric cancer, you can see similar concepts have been applied in patients with early gastric cancer. And this is an important health issue in different parts of the world. For example, in different parts in Asia, in the South American region, and even within the United States, in specific populations such as the African American or the Hispanic population, in which gastric cancer, I think, is missed by us in practice in the US. And this is again the bounding box around the lesion, and also telling you here that there is a close to 98% chance that this area being looked at by you is an area of early gastric cancer. So detection and providing a degree of diagnosis is there for these lesions. Colonoscopy, 19 million procedures of colonoscopy performed in the United States every year. And ADR, or adenoma detection rate, is a quality metric. And we do perform this, and this is one such plug-and-play device looking at its role in the detection of colon polyps during colonoscopy. And we do have a randomized controlled trial from Europe, which has looked at the real-time use of computer-assisted detection, or CAD-E, in patients undergoing colonoscopy. So close to 700 patients who were randomized to HD colonoscopy alone versus HD colonoscopy using the CAD-E device. And they used a CNN-based algorithm for the detection of colon polyps, which is shown right here in the screen at the bottom is the bounding box around the patent. These are the results from this randomized controlled trial. For adenoma detection rate, there was a significant improvement using the CAD-E device. If you look at the APC, or adenomas per patient, that was also significantly higher, as well as looking at diminutive polyps or large adenomas. You can see that the AI device outperformed the non-AI device, or HD colonoscopy. So we can easily see that now we are to a point where randomized controlled trials are being conducted, which is what we need in this field in order to show that it is ready for prime time and can be applied to our patient population. So now if you look at what I've already discussed so far is detection. Now let's see how this can be transformed into endoscopic treatment. So one way AI is helping in early detection, but early detection would not make sense unless you can apply non-invasive therapy, i.e. endoscopic therapy in this patient population. Here's a lesion which is suspicious, but what AI is doing for you is that it's marking the lesion. So it's delineating the lesion for you, and it's telling you that this is an area of early gastric cancer. So if you perform EMR or an ESD, endoscopic submucosal dissection, this is the area that you need to dissect. So it's helping us in endoscopic therapy by now telling you the area which is demarcated here and needs to be resected by you in doing that. Another area where I think we need help is by looking at a lesion endoscopically and then ensuring that there is not, deep invasion. If there is deep invasion, then perhaps that lesion is not suitable for endoscopic resection. And this is, again, a study looking from gastrointestinal endoscopy published earlier this year, which looked at whether the lesions are mucosal or SM1 lesions, which are shown on the left, or on the right is it an SM2 or submucosal or a deeper invasion. And the machine gave a probability score from 0 to 1, with 1 being that there was an extremely high probability of the lesion having a deeper invasion in this situation. And they used AI-based accuracy using white light endoscopy, narrowband imaging, and also images from indigo carmine chromoendoscopy. And no matter which modality of endoscopy they used, they were able to have a very high accuracy or a probability of the AI algorithm being able to separate out whether the lesion was superficial or deep. And again, this is extremely important because of its implications on endoscopic therapy. So that's gastric cancer. Again, for screening and surveillance for colonoscopy that we do for colorectal cancer, finding colon polyps, the ASGE has the PIVI criteria, whether can you resect and discard polyps if you're sure that it is a hyperplastic polyp, or whether it cannot have an impact on the patient's future surveillance. So this algorithm tested something very similar to that. And it uses validation and again, test images as we've gone over. And again, it looked at optical pathology versus true pathology and showed that both for the initial validation images, but more importantly for the test images, the optical pathology performance for the resect and discard strategy was extremely high, meeting the PIVI criteria. Similarly for the diagnose and leave. And this is again something of use in the Western world, where screening and surveillance colonoscopies are performed in our patient population for colorectal cancer awareness. So this is something how it can impact endoscopic therapy in this patient population. So thus far, I've told you all the great things of what AI can do. But like with any new technology, any new tool that we use in gastroenterology and in endoscopy, I do think we need to take a step back and we need to look at what are the limitations. And, we should be the first to admit that as of now, we have only pilot or preliminary evidence. There is lack of consistent evidence that the use of AI does more good than harm. And I think that's important to show. Very few studies have had external validation of AI versus experts. I shared a few published studies with you, but this has not been consistently done in the published literature, and that's important. And finally, I think we do need to show good outcomes. Just showing that it increases one polyp or small polyps is not going to be helpful for us. Does it truly improve patient and health services outcomes? I think that remains to be seen. And I think future studies will definitely evaluate this and look at all of these features of limitations of artificial intelligence. The other thing of all of us as gastroenterologists and endoscopists should start becoming familiar of how to evaluate the machine learning and the AI literature which is being published. We should try to ask these questions to ourselves or to the presenter. What performance metrics do the authors report? And is that relevant? Does the study compare AI performance to a clinical standard? So what was the gold standard or the ground truth that was used in the study? So ask this question. Does this comparison actually make sense of what is being predicted? And is that something which is clinically important? Has external validation been done? Or have they just used an initial, test images and that's it? And if there's no external validation done, the algorithm is probably not as meaningful as one may think it to be. And again, is the system benchmarked against human subjects, meaning were the appropriate patient population tested or not? So We do owe it to ourselves to start asking these questions, because we will be faced in the next several years with a lot of information in this field. So finally, to conclude, I use this to show that this is the promise of artificial intelligence in gastroenterology and endoscopy. It will gather information. However, we will have to train it to tell us what information we need gathered. We will be able to establish better treatment plans based on image enhancement and better diagnosis in gastroenterology. And finally, it will improve patient outcomes in this situation. So again, thank you very much for inviting me to this wonderful Congress, and thanks for your attention.
Atul, I think you're muted.
Thank you, sir. Thank you. It was a great presentation. The thing is, it seems to be infinite. I mean, like, whatever I was reading about artificial intelligence, it's cancer detection, fantastic. Yeah, removes inter-observer variability. And I believe also that the non-cancer part also, where that learning curve from passing out and because I was reading about how you can speeden up your learning curves in standard procedures. So this is an amazing spectrum. I am questionless, and unfortunately, I don't think we have a very proactive right now Q&A session. So I think I'll hand it over to the next.
I might ask a question, sorry, if you don't mind.
Yeah,
Pratik.
sure enough.
Pratik, in your clinical practice, and you are absolutely correct, we don't have patient-related clinical outcomes to apply in daily practice. Is your center using it on a regular basis? That's number one question, obviously, or would you wait for more data to come? And number two, when it comes, do you think the clinicians will need to train them, or it will not require a lot of training, the machine will do a lot of job?
So yeah, thank you, Badra. Excellent question. So the first thing is that in the US right now, there are no devices which have been approved by the FDA. So they're not commercially available. In our endo unit, we are doing 3 trials currently with 3 different machines on polyp detection. So we are currently using it, but only in the setting of a clinical trial. I do think that once a couple of these get FDA approved, that people will start using them in their practice. And initially it will be for, maybe folks who are early in the early career, getting trained, etc., and they want to get better. So for example, adenoma detection rate, right? As to how many polyps are you detecting? If you're already a very high detector, and your rates are 40 to 50%, you may not need the help of this device. But if your rates are lower, 20%, and you want to improve yourself, this may be something which may be valuable for you. So I think that is what will determine and do that. In the EU, I think there are a couple of these devices which have been approved. Your second question about training is also an
But I don't see him. Sham, are you online? Of chairpersons. Thank you, Dr. Amar and Dr. Atul Chawla for joining us in the morning. I would invite Dr. Badri Alam, who is a consultant gastroenterologist at Cleveland Clinic, Abu Dhabi. He has been trained in Australia. He has a vast experience in GI endoscopy. His area of interest are IBD, difficult polypectomies, EMRs, ESDs, third space endoscopy. So I'll welcome Badri. Badri will introduce Sham. Thank you.
Thanks, Yogesh.
Amol, sorry.
No, that's okay. Thanks. So welcome to the next session, obviously, and I have the privilege to introduce Dr. Amol Bape, who doesn't need a lot of introduction. He obviously has kindly agreed to join us despite being very busy as the organizing secretary of Indian Society of Gastroenterology meeting starting tomorrow. He's the chief of GI endoscopy at Shivanand Desai Center of Digestive Disease Disorder at Pune. I had the privilege of doing some hands-on with him at one of the Amit Mahadev's meeting actually. He's not only an excellent clinician, but he's also an innovator, endoscopist. And one of the examples is his latest publication about in which is the first published case series of the long-term follow-up of results of per-rectal endoscopic myotomy in Hirschsprung disease. And he also recently published about a combination of POEM and TIF in the cases of Zenker's diverticulum, which Moin was discussing in his talk. So welcome, Dr. Bape. We look forward to your talk.
Thank you. Am I audible?
Yes.
Am I audible?
Yes, we can hear you.
Yeah, so you can see me and hear me. So thanks, Yogesh, for the kind invitation, and thanks, Badre, for the introduction. I felt very nice about myself, hearing a lot of good, nice things. So I'm going to talk a little bit about endoscopic resection in lower GI today. And of course, it's a topic which has been discussed many times, and some new thoughts and some new concepts. So we know that colonic polyps, the pedunculated ones, are simple enough to be tackled with a snare polypectomy. Is the sessile or the flat lesions, which require a lot of debate, as well as how to resect them in the best possible way. And we know that EMR or ESD, which is mucosal resection or submucosal dissection, are two methods to decide, to tackle these lesions. So we need to start off with understanding that the risk of malignancy in colonic adenomas goes on increasing with the size of the polyps. So larger polyps have a higher risk of cancer. We all know that. And we also know that image enhanced endoscopy gives us improved visualization of the vascular and the pit pattern, and also an accurate estimation of the submucosal invasion. So using these techniques, we can now estimate the risk of cancer invasion in these polyps, and then decide what is the best way forward. Amongst all the so many classifications that are available, I typically tend to use the JNET classification. I think I'm a lot influenced by the Japanese groups, and as compared to the the NICE classification and so many others. Type 1 is the hyperplastic polyps or the sessile serrated polyps. Type 2A are low risk adenomas, as we know that, and that is 2A, and 2B are high risk adenomas, and then type 3 is invasive cancer. So that is what we know that. And also, when we are talking about colorectal lesions, particularly the rectal lesions and the flat lesions, we know that we have these two variants, the granular versus the non-granular. The non-granular being more prone for deep invasion, as well as the granular with some nodular components. There can be invasion in the depth. So that is what we need to remember. And the next thing that we need to understand is that superficial cancers, the principle is that once the lesion invades the submucosa, then the risk of lymphovascular invasion and therefore lymph node metastasis becomes higher. Because of which we know that when the lesion is strictly mucosal, the risk of lymph node metastasis is under 3%. But as soon as there is submucosal invasion, the risk goes up to almost 18-19%. And because of that, it's important that we need to assess the depth of the lesion before planning the resection. The other important point is that the need for en bloc resection cannot be emphasized over here, because endoscopic resection has three important roles. There is a potential to achieve a curative resection. Also, we need to allow for an accurate histological evaluation, which will help us to assess the risk of lymph node metastasis. And we also know that lesions more than 10 millimeters have a higher malignant potential. So because of that, en bloc resection, whatever the modality, EMR or ESD, is necessary to prevent residual or recurrent disease. That we know that. So the typical flow of events for any endoscopic resection goes this way, that we screen these patients for early cancer using whatever modality that we choose to use. including a biopsy, although we prefer not to do biopsies with increasing use of image enhanced endoscopy nowadays and sometimes additional EUS. Then we perform the resection either using an EMR or an ESD technique, focusing on the fact that we need to perform an en bloc resection as far as possible, although piecemeal resections are also performed at specific situations and in specific indications. And if required, there can be additional resections also that can be performed. And the entire specimen needs to be subjected to histology, where the peripheral as well as the deep margin needs to be examined by the pathologist. The invasion depth has to be measured and vessel invasion also has to be commented upon. And that gives us the final diagnosis wherein we can confirm whether the resection has been curative or not, and whether the patient will require follow-up or observation or any additional therapy like surgery. So that's basically the plan. And with that, we know that the two basic steps are procedures are EMR. So we know that the EMR was basically developed for resection of sessile and flat lesions. So what we do is we inject in the submucosa to create a pseudo polyp, and then an en bloc resection is performed. EMR typically it permits us to perform an en bloc resection for lesions up to 2 centimeters, but beyond that it is difficult to perform an en bloc resection, and often we end up with a piecemeal. So this is on the left hand side, you can see there's a smaller lesion where you can see a en bloc resection, and here we can see that a piecemeal resection is being performed both in the same videos, the same slide. So here we can see on the left hand side the lesion has been nicely lifted up, and then we are grasping the entire lesion in one go with the snare and then chopping it off, as compared to the right hand side where we saw that multiple pieces and the lesion had to be taken out in multiple pieces. So the problems with EMR, as we noticed over here, that en bloc resection is possible under 2 centimeters, and larger lesions require a piecemeal resection. And because of that, recurrence after piecemeal resection is to the tune of around 20%. And also pathological examination is often suboptimal because of diathermy artifacts at the margins of the piecemeal resection. Because of that, the concept of ESD developed from EMR, because of the limitation in the resection size, there was an increasing demand for devices for wide field EMR where we could perform an en bloc resection, and because of that ESD was developed. So what is ESD? ESD is en bloc circumferential resection of pathological mucosa through the mid or the deep submucosa so as to peel off the lesion from the muscle layer, and it provides tissue for accurate pathological staging and can also be potentially curative for mucosal cancers with some amount of submucosal invasion. So the steps of ESD are that we mark the lesion all around, particularly in the colorectum. Often you don't require that marking, but in other locations you need that. Then the lesion is elevated by injection in the submucosa. Then the mucosa is incised either all around or on one side, and the lesion is gradually peeled off from the muscle layer to completely resect it en bloc. So let us see some videos demonstrating the technique of ESD. So here you can see a large lesion, and we are elevating it in the submucosa, and now we are performing a mucosal incision at the distal margin, at the anal margin. And then here we are implementing a pocket ESD technique, wherein we perform a small mucosal incision, enter the lesion, and here you can see the muscle layer very clearly on the right hand side, and that's the lesion. And once the lesion has been dissected from the submucosa, we extend the lateral mucosal incisions on both sides so as to deliver the lesion gradually. We can see that the muscle layer is very clearly visible in the depth over here, and we are dissecting in the submucosa. A large number of injectates are available, and that is a different topic on its own, how to perform the ESD. It's a technique. We will probably take that up in question answers if we have time. Here you can see that we are extending the lateral dissections gradually, and then some of these videos are a little bit longer, so I might just jump through some of them. But what you can notice particularly is we can resect the entire lesion en bloc with a good margin of normal mucosa all around the lesion. That is very important. And this is the final part of the mucosal incision, the oral side, and the final dissection and delivery of the specimen. So that is the entire bed of the lesion, post-resection defect, retroflexed in the rectum, and that is the lesion before it is mounted on a cardboard or for sending for pathology. Sometimes, particularly in the rectum, we all have encountered these kind of circumferential lesions, and in this we can usually implement the technique called as tunneling dissection. We all saw the tunneling that Moen described for POEM and GPOEM and other areas. So we use a similar technique wherein we perform a tunnel, and here you can see that the lesion is extending just beyond the anal verge, so it's starting just at the anal verge. So the anal margin is very narrow, so we are cutting very close to the mucosal to the margin of the lesion over here. And using the same technique as you saw earlier, but the difference is that we are creating a tunnel from the anal side orally, and we exit on the other side proximal to the lesion, on the oral side of the lesion. So now the one side tunnel is completed, and then the other side tunnel is created. What the advantage of this is that you can see that that is a tunnel created on both sides, and now what remains is to connect the lateral margins of the attachments, and then the specimen can be delivered. The advantage of this kind of a tunneling dissection is that we can maintain a good amount of traction and retraction while dissecting the lesion, and that is the final defect, a circumferential defect that you can see over here. So once the specimen has been delivered, there is a particular way how the specimens have to be mounted. It has to be mounted on a cork plate or a rubber plate or even a cardboard, and the specimen has to be stretched apart so that the pathologist can get serial sections at 2 millimeter intervals. So the specimen is fixed on the plate itself, and then the pathologist perform the sections. And this is very important because both the lateral and vertical margins in the entire extent of the lesion have to be commented upon by the pathologist, and without that we cannot understand the depth of invasion, so that makes it difficult. So otherwise, some complications of endoscopic resection, perforation of course is one of the main things, and mind you, this often occurs more often with EMR rather than ESD because it becomes it is often undetected also. So here you can see the target sign. You can see that this is the target sign. We've all seen that, and if that happens, then we have to use clips to close the defect. And sometimes of course bleeding can occur, and we have good instruments nowadays to take care of the bleeding. What is important to understand is that we always should use a flushing pump to clean the area so that we can identify the bleeding spot correctly, and then use a coag rasper to stop the bleeding. So that is very important. So using a soft coagulation current and coagulation a coag rasper forceps, we can stop practically any bleeding. So let us look at some of the results of colorectal ESD. Large number of studies. Overall, en bloc resection rates are above 90%, with R0 resection rates of above 85%. And local recurrence is about 7%, and adverse events in about 18%. So majority of them are detected on table and managed endoscopically itself. So post resection survival for early cancers, colorectal cancers, and 5-year survival is comparable to that for surgery for intramucosal or stage 0 or stage 1 cancers. That is very important. So we know that piecemeal EMR has their limitations, that it cannot provide en bloc resection for lesions above 2 centimeters, and periphery of the resection margins may be compromised. Diathermy artifacts is an issue for the pathologist, and because of that, suboptimal assessment can occur. Also, the plane of dissection is relatively superficial, because of which, if it's a submucosal invasion, then probably it is not a curative resection, which leads to higher recurrence rates and risk of leaving behind residual disease, also resulting in frequent follow-ups or re-interventions. ESD in the colorectum, however, although looks very attractive, has its own challenges, because the colonic wall is quite thin, where there is a higher risk of perforation, and also a higher risk of delayed perforation because of diathermy. Awkward position and maneuvering in the endoscope, particularly in the right colon, is often a technical challenge, and visualization and dissection on the proximal side or the oral side of the lesion is quite difficult. The easiest place to start off doing colorectal ESDs is in the distal rectum, because of its extraperitoneal location and relatively thick muscle. And of course, as we discussed earlier, as well as for third space endoscopy, the learning curve is pretty long. So to choose between EMR or ESD, well, en bloc resection is definitely necessary in certain specific lesions. For the lateral spreading tumor, the granular type, if there is a large nodule, there is a risk of invasive cancer under the large nodule. So these require an en bloc resection, as well as all non-granular types are definitely recommended to undergo ESD rather than EMR, because there is a higher risk of multifocal cancer over there. So these are the indications for colorectal ESD, as mentioned by the Japanese guidelines. Lesions which are difficult for EMR, en bloc EMR, and lateral spreading tumors, non-granular type, and particularly the pseudo-depressed types. Lesions showing a type 4 Kudo pit pattern, carcinoma with a shallow T1 submucosal invasion, large depressed type of tumors, granular type lateral spreading tumors with a large or a nodular component, mucosal tumors with submucosal fibrosis after a previous EMR or an attempt at biopsy, sporadic localized tumors in particularly ulcerative colitis or IBD, and residual lesions after an EMR. So these are the indications for ESD, and the European guidelines are nearly the same, although a little bit different. Here we can see that ESD is the first option for non-granular or depressed lesions, and EMR is the preferred option for non-granular or non-depressed lesions. So these are the differences between the Japanese and the ESG guidelines. Lesions. So European guidelines indicate that ESD is required only where there is suspected submucosal invasion. So the Japanese guideline advise ESD for all non-granular lateral spreading tumors, whereas the European is particularly for more than 20 millimeters. This probably is more related to technology, and how ESD has evolved over time, because ESD evolved in Asia and has now spread to the West. So probably experience with ESD is growing in the West. So these are some of the indications. So when we have, these are the treatment options for early colorectal cancers. Endoluminal therapy for T0 lesions, and en bloc resection is required, and T1 with lymph node metastasis is definitely out. So once we have this resection and en bloc resection performed, then we have the final histology, and then we can decide whether this patient can be taken up for just surveillance or further therapy, surgery or chemotherapy. So this is my last slide. A recommended algorithm: large lesion, refer to an advanced resection center, detailed imaging, no concerning features, EMR can be performed. If there are concerning features, this patient has to be subjected to ESD. Larger lesions, preferably perform an ESD, and lesions which have invasion, which are suspicious for invasion, may require surgical consultation or surgery. So this is, to summarize, en bloc resection is desirable for optimal outcomes, and ESD is superior to EMR or piecemeal EMR for en bloc resection, and has significant advantages over conventional EMR or piecemeal EMR. ESD is quite technically challenging and complications are higher but can be easily managed, and rectal ESD is relatively safe. A warm welcome to all of you all for our annual meeting in April next year. So look forward to having you over there, hopefully in person, if the pandemic subsides. Thank you so much.
Thank you,
Thank you, Amol.
That's a very good summary of colonic, how to deal with colonic lesions. Before I open for questions, I just want to welcome our two other panelists, my dear friend Khalid Usman, who is a consultant gastroenterologist at Sheikh Sakhbood Medical City and the director of endoscopy. And I can see Arun Kora is there, who is a gastroenterologist just at a new medical center with Yogesh. Any questions for Amol? I will probably ask a couple of questions. For non-granular lesions, Amol, should we attempt ESD or with the very high risk of, deep mucosal invasion, or should we just refer surgery? How do you differentiate in case of non-granular lesions unless they're clearly cancerous?
Okay, so but I think using NBI nowadays and all these classifications, I think the modified GNet is really very good and gives us good accuracy as far as estimating, cancer risk is or submucosal invasion risk is concerned. So using the modified GNet classification, we can identify and differentiate high risk adenomas from invasive cancers. And based on that, I think we can take a decision of ESD versus surgery in these patients. And I think we would be accurate more than 95% of the times. I think that should be possible.
And the second question is about tunneling techniques in colon. Is it possible to use that in right colon, or should we you'd only attempt that in the rectal or sigmoid lesions?
Well,
technically.
Yeah. See, it's definitely much easier in the rectum. It's most difficult probably in the sigmoid. That's the way I would put it, and in the transverse. And in the descending and in the ascending colon, it's difficult, no doubt, but still you can probably manage it if you take care of the wall thickness, particularly in the right side. But remember that the sigmoid and the transverse have a mesentery, and so getting into the tunnel is really difficult. So sigmoid and transverse colon tunneling is practically never going to be possible.
And is this standard method you use in stomach, for example? Do you do tunneling all the time in the stomach lesions, or how do you select in the gastric lesions?
See, the gastric lesions, I think a pocket is much more commonly used, a pocket technique, because gastric lesions are also, they are wide field. There is also a significant amount of lateral spread and lateral dissection that we have to perform. Tunneling is best for elongated lesions which are along the lumen. So in a tubular organ, tunneling is preferred, but if you have a wider area to dissect, then probably a pocket technique is easier. So in the rectum, you can use either a pocket or a tunnel, depending on whether it is circumferential or otherwise. But in the stomach, pocket is more preferred.
I don't see any question in the thing. I don't know if our dear friend Ammar has any question, or Khalid, anything?
Yes, can I? Thank you, Dr. Amol. Very nice lecture. Can you comment on your thoughts on cold DMR and its expanding role in colonic lesions? lately there's a lot of evidence showing that it's maybe in the future going to be the standard of practice for serrated lesions, non-dysplastic serrated lesions, and there's an increasing evidence of efficacy for adenomatous flat paris to a low risk for submucosal invasion lesions. What's your thoughts on that?
Well, yes, I think cold EMR is really coming up in a big way, particularly for small lesions, diminutive lesions, and also for sessile serrated polyps. It's a very effective modality, I would say, and particularly for the community gastroenterologist who's doing screening colonoscopies and finds polyps while doing a screening colonoscopy. I think it is a very useful tool to have and to implement at the same time during the screening colonoscopy, because you don't need a diathermy. The risk of perforation is practically not there, and unless the patient is on antiplatelet agents or is at a high risk of bleeding or something of that sort, the risk of bleeding is also very minimal for a cold EMR. So I think it's definitely a very important tool in the armamentarium of the endoscopist to implement for the smaller lesions and for the sessile serrated adenomas. However, I would say one thing, that lesions that we saw over here in couple of my videos and also in some of the pictures, those are the lesions which I don't think a cold EMR can address these lesions very effectively. So cold EMR should be reserved for lesions which are incidentally detected at the time of screening colonoscopy, particularly the small diminutive lesions, say up to 5 or 7 millimeters, 8 millimeters, and for the sessile serrated adenomas on the right side.
One more question. How do you routinely admit your colonic ESDs patients, or mostly you send them home same day?
Well, in India, admission is quite not that expensive, so we do admit these patients overnight and we send them home the next day. But I think that's also because of patient awareness, so we don't want issues. That's the reason we do that. I think majority of our patients should be sent home the same day. I don't think there should be an issue. It's just that we've never tried that so far.
Okay, I'll probably wrap up here, and I'll pass it to Dr. Khalid Usman, I'm not sure if our next speaker was supposed to be Dr. You around, Yogesh?
I think Arun will introduce our general manager, and there will be a message from him, and then I will speak. So a brief introduction about Arun. Arun is my colleague, who is a gastroenterologist at NIMS, was a HOD Gastroenterology at Universal Hospital. He's an accomplished therapeutic endoscopist with special area of interest in GI motility as well. So Arun, please welcome as a chairperson. And Dr. Khalid, we all know Dr. Khalid here in this area. He is a director of endoscopy at SSMC, and he is very proficient therapeutic endoscopist, endosonographer, ERCP specialist, and he has been in the area for long. And I welcome him also as a chairperson to this meeting. Thank you. Arun?
Thank you, Dr. Yogesh. Thank you for the wonderful talks we had till now. Thank you to all the speakers.
If I put this on, then I cannot speak.
So Vinay is online. So I would like to introduce our general manager, Mr. Vinay Lazarus, who's been a big support to our team in GI. So with his support, we have seriously grown in patient volumes and procedures in the last couple of years. Is Mr. Vinay online?
A warm welcome to each one of you to our 6th edition of International Gastroenterology and Therapeutic Gastrointestinal Endoscopy Workshop and Conference, the first being in 2015. This year's conference has seen over 700 registrations from over 35 countries. Today, we have eminent panel of presenters, our very own Dr. Yogesh Shastri, and speakers from Johns Hopkins, University of Kansas, Tokyo University, National University of Singapore, Asian Institute of Gastroenterology, and University of South Korea, to name just a few. Yesterday was a virtual workshop, and today's highlight will be the live transmission of endoscopic procedures from Hong Kong and India. Our gastroenterology department at NMC Specialty Hospital, Abu Dhabi, is managed by eminent gastroenterologists. And we have performed close to 800 EUS procedures at our hospital, which makes us one of the largest such centers in the UAE. I'm thankful to each one of you for your participation, and especially to our partners, Asian EUS Group, World Endoscopy Organization, and Olympus. Have a great evening. Thank you.
Thank you, Mr. Vinay. So we will go to the next session. And we have our very own Dr. Khalid, who will introduce will take over the next session.
Hi, good morning, everybody. Thank you for tuning in to this exciting meeting so far, and we're hoping to see even better on ongoing presentations through the rest of the meeting. I'd like to thank our colleagues from the States for making up for the difference in the time. And so far, we've really enjoyed what we've seen in terms of presentations. I think our next presenter is Dr. Yogesh. Is that correct? He's going to be doing the cases.
Yes,
Yogesh is not only an outstanding endoscopist, but a very good friend. So what you hear from me is going to be rather biased, I'm afraid. Yogesh is on the forefront in terms of endoscopic ultrasound in the UAE community, particularly in Abu Dhabi. And he's a therapeutic endoscopist with a variety of skills and armamentarium in terms of providing a wide range of endoscopic interventions. And he's obviously the head of gastroenterology department at NMC Hospital. Yogesh, the floor is yours.
Hello, good evening, everyone. Good morning, everyone. Friends and colleagues, welcome you all for the meeting. And I'll be starting my presentation. I have gathered some cases which we see in recent time, and it will be an interactive session. I will request Amol also to join in if he is there, so that we can discuss some of these cases, and we can see what is the best management plan for these patients. So this was a young 41-year-old female who had a left upper quadrant and left flank pain. She was seen by a urologist colleague and was found to have soft tissue density in the gastric lumen. And this was the CT scan of the patient. As you can see, there was a lesion in the stomach, in the posterior wall. So this was the first endoscopy for her, in which we find rounded about 2 to 2.5 centimeter lesion in the posterior wall, upper stomach, next to the lesser curvature, with a central umbilication within it. And we took a biopsy for it, which came out as a neuroendocrine tumor. So I did a EUS also for the patient, and it showed up a well-defined hypoechoic lesion. You can see very well muscularis propria all around it. So this was a neuroendocrine tumor for this patient. So we decided what next for it. So we decided to do an endoscopic submucosal dissection for this patient. And this is the video. It's a little bit longish video, but I'll see if I can go through it a bit quickly. So this is the lesion which was seen. And as the first step, as Amol is the expert here in ESD, so you have to first mark it. So we used a dual J knife to mark all around the lesion. so as for us to know how much to cut and where to cut. Then we injected it, elevated it. We used a special solution, which is called as a blue, and we elevated this lesion and started cutting it using the dual J knife. The first step is to enter within this space, submucosal space, which is the toughest. And this was gradually dissected. And stomach is a very vascular area, and you tend to have a lot of blood vessels when you are dissecting. And neuroendocrine tumors are known to bleed because they are very vascular, as all of us know. So there was a lot of blood vessels, so it was tackled using the dual J knife itself. The advantage of this knife is that you can inject as well as you can cut at the same time. So you don't have to change the accessories when you are doing the procedure. And we kept on elevating, kept on injecting this lesion to elevate it, to separate it from the submucosal plane. Sorry. And then we encountered some major bleed, for which we took the help of a coag grasper. So coag grasper is something like a biopsy forceps, which has a current at its tip, so you can go hold the bleeder and stop the bleeding. It's very useful for other areas of GI bleed as well. Since the tumor was in the upper part, so you have to retrovert and cut along. And we went over the lesion. It's not really easy for the initial procedures. I took the guidance from Amol also for this procedure. And these are the last steps of the procedure. And this is the last flap which was cut. This was removed using a Rothnut basket, the tumor. And this is the lesion post-surgery, post-endoscopic resection. And this was the CT scan of the patient post-resection, which showed the tumor is out. So discussion, how do we go about the ESDs, and how do we do a proper endoscopic evaluation not to miss these lesions? Of course, it was a little big lesion, but sometime if we are quick, then we might miss smaller lesions. So what do you think, Khalid? How do you go about doing a routine endoscopy?
So, Yogesh, what I would say is obviously a fantastic job, a very excellent video demonstrating that, how this lesion was removed. And I think it may be a very useful idea that during this time we talk about doing a proper upper GI endoscopy. We have all been sort of very tuned to the idea of withdrawal times within colonoscopies and spending time to examine carefully. And I'm afraid that we may not necessarily do the same when it comes to upper GI endoscopy. Myself, I'll put my hand up to say that I don't necessarily spend as much time as I would like to. And this is the time in which you get really to inspect the upper GI tract and be able to detect subtle lesions. I know you've demonstrated here a very good ESD for a neuroendocrine tumor, but I think I'll ask Amul, what would be the commonest indication for your ESDs within the stomach? Would it be submucosal lesions like this, or sort of more like early gastric cancers?
Amol, you're muted.
Right. So globally, if you see, I think early gastric cancers are the most common indication for ESD, particularly in the Far East, in Japan, Korea, China, and those parts of the world. I think the incidence of early gastric cancer is not that high rest of the places in the world, but still in our scenario, whenever we're doing gastric ESDs, I think early gastric cancers form about 50% of the lesions that we encounter. The remaining being either neuroendocrine lesions like this, or sometimes even large, very vascular hyperplastic polyps, really big ones, and those are also lesions or adenomas in the stomach that we encounter occasionally. So about 50 to 60% of our case volume would be early gastric cancer, as compared to about 90% in the Far East, and remaining are these other lesions that we are talking about. Uh, I would say that about 20 to 30% of our cases, we ESDs in the stomach, we do for neuroendocrine tumors. So it's not that low, it's not that uncommon. That's what I mean. That's how it is.
So I think so. So for us to be able to detect these early gastric lesions, one have to be sort of very cautious in terms of the examination, in terms of
Right.
using your time to wash very clearly, inspect, make sure you've covered all the stomach. Our colleagues in the Far East have now AI, and we've heard about the use of AI in endoscopy in terms of mapping the stomach, making sure that all the stomach has been visualized, and the automation will also take pictures of all the areas within the stomach. One of the things I particularly find challenging at times is when you're doing an upper GI endoscopy and the patients are really under sedated. And I think this is an issue. I think to be able to do a proper upper GI examination, patients have to be really quiet, settled for you to be able to do this. Badri, any thoughts on that?
I mean, totally agree. I mean, we do have an advantage as you of being an anesthesiologist, but obviously that's not the luxury. But you're right. Even if you're doing like Barrett's biopsies, for example, simply if these are typical, smoker patients, obese, they're coughing all the time, and it's very difficult to do even a proper examination. I mean, Ammar is here. We recently had a patient who had a very subtle lesion, which basically early gastric cancer, a South American guy, basically hiding on the posterior wall. I'm not sure how I picked it up. I was surprised myself, actually. Amar, do you want to comment something on that? I mean, how inspection is so important when it comes to doing EGD, as Khalid is talking about? Yeah.
Yes, thank you, everyone. It's a really important topic, and I think that there's two things I would probably just.
Ammar, you're muted.
Hi, can you hear me now?
Yeah, yes, we can.
Yeah, sorry. Yeah. Thank you. I agree with all the comments that colleagues have made. It's a good advice really for people really to find these lesions. When you have an atrophic stomach, you really need to slow down, because when you have a gastric atrophy where you've lost the rugae, and especially in a youngish population, especially if there's a H. pylori infection or recent infection, these are the high risk patients. And also when you find intestinal metaplasia. I mean, 2 weeks ago we picked on a a 2 millimeter poorly differentiated cancer in an Indian youngish guy, 32-year-old. Who's he just had a sporadic cancer, and he's coming for ESD, and it's a small lesion, but it'd still be within the expanded, I guess, recently accepted criteria for proceeding with ESD with hope to cure. But I think the two things I would say, intestinal metaplasia and atrophic stomach. The other thing I think also, for those of us who starting to do ESD, I think we should really not underestimate the importance of traction techniques, because it really saves a lot of time. I've lately been using a lot of clip and snare technique, and I would say it at least saves me 30% of my ESD time, especially in the last sort of 20 to 30% of your dissection. I don't know whether Professor Amol has
I think Amol is an expert in this. So
Yeah, I totally agree with Amar regarding the retraction part. We do need some kind of retraction. Now, variety of methods have been designed, a clip and line or a rubber band with rubber band technique and so on and so forth. There are retraction clips nowadays available. So there are a lot of things that are available for retraction, but one has to get familiar with one or two techniques that one is you know comfortable with, and then go on with that, and at the same time improvise. Some kind of improvisation is also required. As I mentioned, a pocket technique or a tunneling technique is another very good way of maintaining retraction at the time of performing the ESD. And I agree with Amar that the last 30% of the dissection is when you need the retraction the most. Also, would like to mention that is also the at the beginning of the procedure, when you need to get into the submucosal space, that is the time you need retraction a great deal. One point I would like to make about early diagnosis, and I think there's a very nice paper by Professor Kenshi Yao, which has actually demonstrated the how to perform an EGD, and I think we all need to read and refer to that paper when we are performing these our EGDs. So we have about 3 years ago we started giving our patients a mixture of simethicone and N-acetylcysteine about 30 minutes before the procedure, and that really makes a lot of difference, because as a mucolytic and also a defoaming agent, your EGD, the views become very clear, and you can really see a lot more than we would otherwise. The other important thing is adequate distension of the stomach is very important. Without that, one is likely to miss smaller lesions or smaller pathologies within the mucosal rugi. So that is another important message for everyone who is attending this meeting. So a good distension, and I totally agree that the patient has to be quiet. Whether you want to sedate the patient or put the patient under anesthesia, or you want to talk to the patient, as we often do in India, not all EGDs are performed under conscious sedation, but it is important. The bottom line is keep your patient quiet, you'll do a better job. That's important.
What do you say about complications, Amol? What's your
complications of
What's
ESD?
your opinion on complications of procedure, Amol? What do you say for the beginners who are starting to do?
Right. See, I'll say one thing. Any therapeutic procedure in endoscopy, there's definitely a possibility of complications, and it's always there more when you are new to the procedure, when you're fumbling with the basic steps and all that. So as Moin also mentioned in his talk, I was listening. So training is an important part. So hands-on training first on animal models and other things, that's very important to for to getting exposed to various situations, how to tackle complications. See, what training does not really you know av- confirm that you will avoid every complication in your practice, but it will just make you aware of a complication. If it is likely to occur, you can preemptively treat it or avoid it at that point in time during the procedure. Or if you encounter it, then you know what to do, and you don't falter, and you don't have to rush to your surgeon to call up your surgeon to take the patient for surgery. So that is important. The commonest complications, as we know, is bleeding and perforation. These are the two commonest things. And as I showed in my presentation also, both of them can be very easily tackled, because endoscopically itself, because keep a high index of suspicion, keep follow the basic principles and steps of ESD, and follow try not to go too deep, and follow the tissue planes very well, and preemptively treat vessels, and I think that should take care of it in majority of the cases.
And what's your opinion, Amol, on the like a lot of us don't have that Apollo stitch or sewing possibility. So is it really a must for those who are starting, or the clips or OVSCOs are good enough?
See, I think we have a lot of closure devices, Yogesh. Overstitch is a good device, but honestly, we've never had to use it to close a ESD perforation. I think most ESD perforations can be treated and closed with simple clips alone, I don't think even an Ovesco is required 90% of the times, unless you really go ahead and open up that hole that you have created. So what is important to understand is that if you identify a perforation, see, it will usually be very small. It will be the tip of your knife. That is approximately the size of the perforation that will occur. What is important is close the perforation then and there, and then proceed with your dissection. That is important. If you leave that perforation, then your dissection will, increase the size of the perforation. And if you continue your dissection without closing the perforation, then the size will increase, and then subsequently it will make it more difficult to close. So close the perforation and then proceed with your dissection and complete it. That is what. And then of course, if you need additional few clips, you can put that at the end of the procedure.
And like we have experience for EUS, like you need really a trained cytopathologist to know it, like what brain doesn't know, mind cannot see. So does it apply to this also? Because these specimens are really quite different from the surgical specimens. So do you feel that there is a need for dedicated pathologists? Because in our area, we are just starting to do these procedures. So some of them may not really be tuned or oriented towards it. What's your comment on that?
See, I fully agree that our pathologists need to get oriented to understand and how to evaluate these ESD specimens. The reason is that it is the protocol which is very important. As I mentioned, 2 millimeter sections, and what you can do to help them is mount your specimen correctly, mark the oral and the anal side of the lesion so that they can comment on it better, and mount it on a cardboard or a cardboard, and then send it across for fixation. And then the pathologist should not just you know dismount the specimen and then use it as a regular specimen, but make sure that photographs are taken properly. And then the sections also have to be at 2 millimeter intervals, and the pathologist probably need to spend more time on the specimen because they need to examine multiple sections. So the entire now imagine a 5 or 6 centimeter lesion. 2 millimeter sections would take almost 30-40 sections would be taken, and then all those sections have to be examined at every point in time in the this thing, so that, see, because there can be deeper invasion and in some of the areas, so unless they see the entire of the specimen, they may not be able to comment. So that protocol, following the protocol, is more important, and they will get better. And I think we grow as a team, so as our skills grow, their skills as well as grow as well, and I think it complements each other over a period of time.
I really agree with you, Amol, and I echo what you said. I've joined here in the region about 12 months ago from Australia, and one of the things that I didn't experience before is the pathologist that needed support really to understand. If you do an ESD, and they don't even comment sometimes on the margins and whether it's clear or not, and with just by talking and just getting them on board and working as a team, now we have completely different service, and they become even more competent, and they buy into it more, and you just have to really support them to know exactly what you want.
Exactly.
Well, one more thing I want to ask you, Amol, how do you manage what's your thoughts on gastric dysplasia? These, I guess, are more common things that people, the general endoscopists, can find, and how should these lesions be managed? Gastric or upper GI dysplastic, even low-grade dysplasia. How should they be managed? Thank you.
Okay, so I think if it's low-grade dysplasia, you need to discuss with the patient the options, and if it's a focal low-grade dysplasia, then you can probably offer an ESD for these patients. However, if it is a large field or a multifocal low-grade dysplasia, then these patients probably need long-term surveillance with them understanding the importance of long-term surveillance with the possibility of cancer and developing in future. So I think if there is any concern regarding that, then the patient definitely requires some kind of intervention or resection of the lesion. Now, as I mentioned, if it's a focal area, then probably an endoscopic option is good enough. But if it's a multifocal or a wide field area, then probably it may also require surgery. Although my threshold for offering surgery for a low grade lesion would be very low. If it's a high grade lesion, then of course, you need to do something quickly. That's the way it is.
Thank you for the panel. This is a very interesting discussion and case. Just before we wrap, a couple of things. So I'll put a question from the floor, which is, what's the best agent for mucosal submucosal lift?
I think
Gelofuscin. There are a lot of agents available. I think Yogesh had the advantage of using something else, I think. But in India, I think Gelofuscin is very cheap, about less than 400 rupees. And we use
but unfortunately, we don't get it here. It's not available in this part of the world.
Okay.
Yeah, I agree. I mean, in Australia, like you, Amol, we were very happy with Gelofuscin for all the EMRs and ESDs, and we didn't need really the other, more, consistent agent. But here, I've trialed with multiple agents, including even albumin 20% as a viscous to try and, and there's just nothing here in the UAE that really is good. And I ended up having to, I shouldn't be saying this, but currently I'm using Orize with, top up then with saline, but that's probably the best solution that I've settled for here in the region. But otherwise, it has been an issue, and it's very, very inefficient when you're just going with saline and trying. But I guess the if you're using a flush type knife, it's still, you can do the job, definitely. And I think flush knives are almost a must nowadays for efficiency with all these busy units that we have. Yeah.
So I think we'll go to the next case, because we have a couple of more cases, so we'll go through it. Amol, if it's okay, you can stay for from 15-20 minutes if it allows. I know you are very busy with your commitment tomorrow at the big event.
I have a lot of things.
So this was a 47-year-old colleague who has chronic dyspepsia with reflux. I did his upper GI endoscopy, found some hiatus hernia. But when I was doing the upper endoscopy, I found that the ampulla was a little bit prominent, though with sometimes with the forward viewing scope, you cannot really see the ampulla very well. I put in a side viewing scope and I really found that ampulla is bulky. I took a biopsy. It again came as neuroendocrine tumor. We did a screening colonoscopy, which showed some adenomas in the colon. He had normal serum gastrin, chromogranin. We did CT scan, which to our surprise really picked up some bulky part in the ampulla. And patient was posted for ampulectomy. So this is again a short clip which shows the bulky ampulla, really not very big. By Khalid standards, I think Khalid is used to a bigger ampullas. So it's really not a very big video. So we did a full workup, and after that we went ahead with the ampulectomy for this. As we all know, this area is very, very delicate because there is opening of the PD and CBD at this place, and the duodenal wall sometimes can be very, very thin and can cause problem. Another problem is the duodenum moves very fast, so you can really lose the specimen very fast sometime if you are not quick enough to grab it. And so this was a post-resection image. Then I tried to cannulate him to look for his PD, because you always try to put a PD stent after this because incidence of pancreatitis is very high. So unfortunately, I was not able to succeed in that. But I cannulated his CBD, did a sphincterotomy, and then we went ahead and put a CBD stent. There was some remnant I felt of the ampulla, of the ampullary area, which we removed. And I put a double pigtail stent for the patient. But what happened on the second day, he was fine. He was started orals, actually on the next day itself. He was about to be discharged on third day morning, but he complained of bloating, giddiness, hypotension, and vomiting. And he didn't have a melena, but hemoglobin dropped to 9 grams. I did his urgent upper GI endoscopy, and we found there was a lot of blood in the stomach. And when we went into the ampulectomy site, we saw there was continuous ooze from that area. It was little difficult because I used a double pigtail stent to, I used double pigtail stent. It was not Amsterdam type stent. So I used again a coag grasper in that region to arrest the bleeder. But it was really a stubborn bleed. It persisted despite that, and I did not want to use too much of coag there because I knew it's post-resection. There's a thin mucosa there. Then we started putting the clips, and then we stopped counting. We kept on putting one clip, next clip, and it kept on bleeding. And I really wanted to be really sure that it has stopped. Then this is the final picture. Almost 9 clips I put. And I also injected dilute adrenaline carefully because it was at the inferior margin so as to not to block the PD, because we are also worried about pancreatitis and if you inject in that region. So this was the final picture. Then he was discharged after a day or two. We gave him some IV iron. We did not give him any blood transfusion. He presented to the emergency 1 week later with fever and chills. And we did a CT scan abdomen, and to our surprise, really, it's a VIP syndrome. We found a small abscess in the liver. So we treated him with IV antibiotics, and he settled and he's fine. He came for follow-up 3 months and he's doing well. So again, opening up the Pandora's box for ampulectomy. What's the workup? What should we do? What is the approach? So Arun, what do you think? What should be the approach for a workup for ampullary lesion? Dr. Arun?
Arun, you're muted. Yeah. Okay.
Yeah. The most important workup would be imaging, especially endoscopic ultrasound, to know the depth of the lesion and all that. One confusion I have: how important is to have a CBD stent in situ after this procedure in an ampulectomy? This is
Khalid, you want to take it?
Arun, I completely agree. Before you embark on an ampulectomy, one would need to know whether there is extension to within the ductal system, be it the biliary or the pancreatic system. And obviously the best thing for that nowadays is an endoscopic ultrasound. So if you just take this one step back, I would say that ampulectomy is more of a science, more of an art than a science. You will never see any sort of major society guidelines which are particularly based on scientific data as in trials, really. There is no clear-cut guidance on use of EUS, but I think in this day and age, I would say that an endoscopic ultrasound is an absolute must to decide this, because essentially, if there is ductal extension for more than 1 centimeter, then this is out of the realm of being tackled endoscopically. So I concur with that. Again, when it comes to the placing of stents, so we've all been sort of trained and attuned to the fact that we need to place a pancreatic stent in an attempt to reduce the chance of pancreatic post-ERCP pancreatitis and ampulectomy. I suspect this is from the theory that when you apply current to the pancreatic orifice, you may get edema and subsequent pancreatitis. However, one of the tricks I've learned some time ago from Marty Freeman in the US is that a pre-ampulectomy MRCP can sometimes resolve the situation, because I suspect that an experienced endoscopist like Yogesh wouldn't have missed the PD after an ampulectomy. The patient may simply have had a divisum, and therefore, that is not really necessary. And the issue about which you've just raised about placing a biliary stent, remains really up for discussion. I personally don't do it. This is a plain by the ear. If I felt that the ampulectomy, and usually there's slightly, if you're doing a slightly bigger ampulectomy, you'd see a very wide open biliary orifice, then I don't do anything. Alternatively, if I felt that's not the case, I'd do a small controlled sphincterotomy rather than placing a stent. And the reason is because I am not as good an endoscopist as Yogesh, is that I get a lot of complications with ampulectomies, a lot of bleeding, occasional perforations, and having an endoprothesis can sometimes make work difficult, as we've just seen.
Stent is, plus minus, but sphincterotomy is a must, I feel, after ampulectomy, because what happens, whatever evaluation you do, sometimes we are still not able to see the lower part of the CBD. So unless you cut the sphincter, because sometimes what happens, even after all the evaluation, you do the ampulectomy, and when you do the sphincterotomy, you can, when you just cut adenoma or something bulging out from there, so it would definitely be missed and going into the CBD. At least a cholangiogram is a must, and yes, sphincterotomy and stenting depending on the preferences.
I think that the other point, Yogesh, that you made very well, which is that your sample, going away. So this is not a situation in which you cut and then you start asking the nurses to find your roast net. This is roast net out, ready to go in as soon as you make the cut. The last thing you really want is to lose your sample. That makes it really challenging and difficult. I think the other thing, and we talked about this a number of times, Yogesh, is having stuff to deal with your complications also fairly handy, be it clips, be it injections, and even I would say as far as having a covered metal stent really nearby as well to deal with small perforations.
And what's the role of prophylactic antibiotic? Do we really, because we never give, and as you said, there are no guidelines on it. So I think it's a very open area for using the antibiotics post ampulectomy.
Arun, what are your thoughts on this?
Retrospectively,
okay, so we'll go to the next case. This was a 42-year-old female who had a 42-year-old male who had high-grade fever. The lab shows features of cholangitis. He had a high procalcitonin. Blood culture has Klebsiella pneumonia. Ultrasound and CT abdomen showed a large collection in the liver, which was in the caudate lobe of liver, which was very difficult to be reached by intervention radiologists. So the surgeon asked me if we can do anything about it. Can we get some sample? Can we aspirate this this lesion? So this is an ultrasound picture. So we went ahead and did an endoscopic ultrasound for this patient. So this was a large abscess, more than 5 to 6 centimeters in the caudate lobe. And did a US guided aspiration for this abscess. Used a large 19 gauge needle because the pus was very, very thick, and almost emptied it. And this is the abscess post aspiration. And this is the pus which was sent for culture. And this abscess aspiration was done, and after about, the patient started improving from the day we aspirated. He was discharged after 5 days with antibiotics. Is on follow-up, is totally asymptomatic. So we have Lawrence also here. We have Dong Wong also. So Lawrence, any experience with non-conventional uses of EUS, which are not really so well established? So like drainage of the abscess. What's your take on it?
You're referring to what sort of abscess? I have drained perigastric abscess before. So certainly, I think it's the same way as draining a wall-off pancreatic necrosis. Yeah, that happened, I think, because there was a so-called perforation because of the procedure, gastric procedure causing perforation, but the abscess was sealed off. So we drained the same way as putting a axial stent in. And after that, obviously, I think the thing drained and we removed it within the 2 weeks. And the entire abscess cavity by that time cleared up very well. So this is something that certainly I think can be done. I guess besides perigastric, you can do the same thing for perirectal abscess as well. So those collections are very amendable. I think things which are next to the GI tract, they are quite amendable to EUS guided drainage.
I think Khalid has a lot of experience on abscess drainage, especially in the rectal and perirectal areas. Khalid?
So yeah, again, I concur with Lawrence. So if we think as the GI tract as a sort of a tubular structure, most of the viscera and structures around it are amenable to access with EUS guided drainage. We've seen, I recently drained what we've talked about this, Yogesh, a perirectal abscess by placing a luminoposin stent, again, with very good success. And obviously, if we can sort of go for a non-invasive approach for these things, that would be helpful. I think increasingly people are using EDGE as well to drain, to access gallbladders and stuff like that. I think that the trick to doing this, because to be able to get the patients and to deliver this service, you need to be working in a multidisciplinary team. So your surgeons, your radiologists need to be on board with this to know that what is really amenable, what is accessible for EUS, because you have to remember, only a few years back, everything either used to be managed either surgically or radiologically, and particularly surgically. So for example, if we compare to what used to be done in terms of the walled-off necrosis in the bad old days, where people used to have to open laparotomies for this, and we know very clearly that the evidence now, that this is really gives you a much significant morbidity and mortality. So awareness of your team, working in a multidisciplinary context, and as Yogesh has demonstrated here very nicely, that a relatively quick procedure in the right hands, you can really contribute to patient care very effectively by doing this procedure.
So I will wrap up with the last case. So this was a 41-year-old female. She had a typically biliary obstruction. She was referred for ERCP, and we found some stones in the lower CBD, which were removed by ERCP. But her imaging also showed something in the right intrahepatic duct. So this was a stone in the right hepatic duct, which was really, really very deep. So she had something like a RPC, and we subjected her to a cholangioscopy, hoping that we'll be able to reach deep. And it was really, really a difficult area to go in. As you can see, we are progressing along, and then the scope was really totally twisted when we wanted to go into the right hepatic duct. You can see the stone there, but we tried to bring out the laser fiber in this area. It was not just moving because the scope was almost deep into the right hepatic duct. As you can see, this is the stone here, and have some fluoroscopy images, hopefully, in this. So when the laser fiber was, so as you can see, the cholangioscope is so deep here. So the laser fiber was not coming out. We tried to put in a basket. We took it really to the tip of the scope, and then we tried to cannulate freehand, but it was not coming out. Then we put a guide wire and we went across it, and then we inflated it and then removed. So we could remove one stone, but she had 2 or 3 stones. So we could not really clear the entire CBD in this approach. So now cholangioscopy has started in this part of the world. There are few centers which are doing it. So I wanted to ask the experts, what is the view on this? Arun, what do you think of pre-procedural antibiotics? Should we be giving it or not? What's the practice?
Especially this sort of intrahepatic stones, definitely we should be doing it. Giving pre-procedural antibiotics.
Okay.
Is,
Khalid, what do you think of indications for cholangioscopies? So what?
So I think as most of us will know, is so there is the indeterminate biliary strictures, which we've for a long time we've struggled with in terms of getting a brush cytology without a significant yield. So that's a very good indication when you've got indeterminate strictures, biliary stricture, particularly high ones, high up ones. There's obviously the big stone disease, albeit in the within the common channel, or as you've shown us within the liver. I have to say, increasingly in Abu Dhabi, in the UAE, we're seeing this really very large stones within the liver, within the liver biliary tract, within either one of the subsegmental even branches. And as you've shown here, you can get very deep, but the maneuverability once you get within the liver, I've seen from the video that the stone you're trying to do is in a corner, so you've got a long the cholangioscope is in a long position, torquing the scope to go into the side branch within the liver I find that particularly challenging. So that's always a challenge, and obviously I think. When you're dealing with this, one have to really be ready for a very long day, 2-3 hours. And I have to say, manage the patient expectations and everybody's expectation that this is going to take some time, and success, although it's a good percentage, one cannot guarantee that it's going to be 100%.
So I think there are a lot of cases, but I think I will end it here, and we'll take a. This is my team. Without my team, I cannot do anything. I thank my entire endoscopy family for being a big support to me. I think we'll take a break for 5 minutes, and then we'll join for Lawrence's lecture. Lawrence, is it okay? We can take a 5 minutes break. We started at 8 o'clock.
Sure. Yeah, go ahead.
Yeah. So we'll take a break, and we'll meet at 10:25. Yeah. I think we'll start the next session. For the next session, I would invite our chairpersons. So first chairperson is Dr. Mazin Taha. He is the head of the department at Tawam Hospital, ALIN, and is the chief of the gastroenterologist and chairman of internal medicine. He has been trained extensively in Germany. He is in UAE for a long time, and he is renowned in the field of therapeutic endoscopy, GI oncology, and biliary intervention. Welcome, Dr. Mazin Taha. I will also invite the second chairperson, Dr. Makki Fayad. Everybody knows Makki in this region. He's a very senior gastroenterologist. He's a consultant gastroenterologist at ACDS. His main areas of interest is video capsule studies, motility, and IgG4 diseases. Our third chairperson for today is Dr. Salim Awad. Salim Awad is a father figure of gastroenterology in this region. He is a consultant gastroenterology at his own center, Advanced Center for Daycare Surgery. He is a very dear friend and is one of the most wittiest and intelligent gastroenterologists I have seen. A lot of common sense, and his internal medicine is fabulous. So he's not only a good gastroenterologist, but he's an expert in internal medicine. I'd request the chairpersons to take over from here and take us through this next session. Thank you. Dr. Mazin. You are muted, Dr. Mazin. You are muted. Please unmute.
Okay.
Thank you.
Thank you. Just a minute, please. Just a minute.
Yes. Doc.
Hello. You hear me?
Yeah.
I have difficulty to see the program.
Dr. Mazin, you have to introduce Dr. Lawrence Ho, who is the next speaker.
Yeah, moment.
So I will introduce Lawrence. Lawrence is a senior consultant at Division of Gastroenterology and Hepatology at National University Hospital. He is the founder of Asian US Group, very astute clinician, gastroenterologist who thinks a lot, and he is the backbone of Asian US Group. He was here with us in one of our meetings a couple of years back. I'd welcome Lawrence, and Lawrence, please give your disposition. Thank you.
Thanks, Yogesh, for this kind introduction. So I think, yes, Yogesh has asked me to talk about something which is outside the topic of EUS. So I think I quite like this suggestion because I think this is something also very dear to me. And for today's talk, I'm going to take you through a slightly different angle, essentially on robotics. So I think Yogesh has kindly given me this particular topic, which is called robotics in endoscopy, how far still? So I think he's trying to ask me, when are we going to see robotics in our daily practice? I think in order for me to answer this question, maybe I can briefly take you through my own journey towards this particular innovation, which is called flexible robotic endoscopy. So this is something which is, while this is still quite new, I believe that this is going to come very soon. So let me perhaps try to convince you about this possibility. I think we did write an editorial not too long ago, or somebody else wrote an editorial on this particular topic not too long ago, and actually mentioned about our particular innovation coming from Singapore. So it's kind of phrased the same way. Robotic endoscopy in gastroenterology, has it come of age? So maybe I can take you through, I think, how a particular typical innovation is finally being adopted into clinical practice. I think firstly, whenever we come up with a good idea, a solution, we always have to see whether this particular solution can actually solve certain unsolved so-called need. And this is where I think the first question we need to answer is why robotic endoscopy? So why actually bother to incorporate robotics into our daily endoscopy? So this is why I think that was also the initial reason why I think we came up with this idea. If you look at how we do endoscopy, I think everyone here is familiar with the manipulation of endoscopy. We always know that we have this scope, and which allows us to sort of turn the scope up and down to the side and so forth. And also, I think allows us to put certain things in through the working channel. And then this is how we perform endoscopy now. But if we eventually have this goal that we want to be able to do surgery like the surgeon, then I don't think we'll ever be able to achieve this goal, because if you look at the surgeon's arms, they have two arms, whereas we only have one arm. So this is why I think it's very hard to achieve the so-called basic tenets of surgery. So how does a surgeon actually do their surgery? So essentially, they have to achieve certain so-called certain principles. Firstly, they need to have tension through retraction in order for them to be able to cut as well as do certain things like suturing effectively. And secondly, they always need good exposure, because without this visual feedback, they will not be able to do as precisely. And obviously, I think they all need tactile feedback in order for them to know how much force in order to apply to the particular tissue. So all these are the basic tenets of surgery which any surgeon will understand and master. And then to do so, I think they are helped by the fact that the two human arms are actually quite amazing. They can do whatever those three things: triangulation, grasping, and so forth. But however, if you look at an endoscope, we actually do not have all these three things. We only have this small little working channel to manipulate. So I think it's actually already amazing that we can achieve so much. But moving forward, I think there is a need for us to think about how we can actually put two arms in order for us to achieve those goals. And this is why we came up with this so-called robotic arms many years ago, essentially to achieve those tenets of surgery. So I think moving forward from the unmet need, okay, for any innovation to go into the market to be adopted, we also need to go through some basic sort of journey. Firstly, we need to prove that this particular concept, which I just mentioned, can actually work. And after that, very importantly, we need to prove certain values. Otherwise, this particular innovation will never be adopted. Okay, people don't see the value, they will not adopt, and they will not actually, I think your question about how far still. So I think I'm going to show you three particular so-called POC and POV studies. Firstly, I think the endoscopy, the flexible endoscopy robots can actually shorten our learning curves in doing certain complicated procedures. So a number of years ago, we did do a particular trial using our prototype flexible robotic endoscope. And the trial is conducted using so-called ex vivo gastric model. And this is done by essentially asking two groups of endoscopies, or so-called two groups of people, to try to do gastric ESD. So one group of these so-called operators were completely untrained people. They've never done any ESD in their life. So this is one video of one of the particular operators. She's actually a Japanese engineer who has never done ESD. So she was given a training which is lasted for less than 30 minutes. And after that, she was asked to do the ESD using this particular robotic endoscope. So I'm just going to summarize the results. Essentially, these graphs show the time it takes for the different steps towards ESD between so-called experienced endoscopies versus non-experienced endoscopies. Obviously, you can see that the time taken for non-endoscopies to complete the ESD is longer than the time taken for endoscopy to complete it. But very importantly, I think it did show that even non-endoscopy could complete the ESD in good time, given very little training. So our final conclusion in a publication concluded, say that the particular robot called Master enable non-endoscopies to complete the gastric ESD. So if you think that the publication is biased, I'm going to share with you another publication which came out from a different robotic endoscope system. And this is a MET robotic system, which again showed the same thing. And this time they use a colonic ex vivo model to perform again ESD. And also they use the same group of people. Okay, not two separate groups. They used a group of endoscopies which had no ESD experience. Okay, they were given some training, and after that, they compare them using the robotic system versus using the conventional ESD method to perform colonic ESD. So these are all inexperienced endoscopies. So to summarize the results, if you look at it, what they found is that I think 100% of those endoscopies who use a robotic system were able to do complete resection versus only 50%, okay, of the inexperienced endoscopy managed to do the ESD using the normal conventional method. So I think there's a big difference. And secondly, also the time taken for the endoscopies to do ESD was shorter if they use the robotic system versus if they use the conventional system. So this is a sort of a proof of concept, which I just mentioned. So I think to me is I think two separate studies, independent studies, show the same outcome, meaning that I think it did. I think the robotic system did shorten the learning curve of certain procedures like ESD. So moving ahead, I think I believe that the second value. So this is again something which we have to prove the proof of value of endoscopy robots is in helping us to do certain complicated procedures. So I think the first complicated procedure which we actually prove the concept is in doing so-called human gastric ESD. That was achieved in 2011 when we use our system, which is quite basic at the time, is 2011. That's a version 1 of the EndoMaster system, which is a flexible robotic endoscope system. And then we managed to complete 5 human cases of gastric tumor resection using this particular robotic system. So this is done in a live case demonstration, okay, between Philip and myself in Hong Kong. So I think, and moving on, we also sort of proved the concept that we could use this same system to perform what we call the endoscopic full thickness resection in an animal model. Okay, I will not have time to go in the thing, but the full results were published in the particular journal, Surgical Endoscopy. So I think essentially we show that I think using the robotic endoscopy system, we could operate, okay, and we could actually do a full thickness and then after that suture it back at the same time. Okay, so moving ahead also, we actually did a very brief, I think simple proof of concept study to show that this flexible robotic system could be used to perform what we call a simple nodes procedure, which in this case, the model for the nodes is actually what we call the liver veg resection in an animal model. So I think because there's a sound system here, I could not clear it. So I'm just going to briefly explain while the sound is actually going on. Okay, this is a very basic system. It was a version 1 robotic arm system. So as you can see, one arm is so-called the grasping arm. The other arm is the cutting arm. So it just cuts through the liver like any surgeons would be doing. And this, in this case, is operated by a single operator, which goes in and I think it kind of approach, access the liver through a gastrostomy, which was again achieved through cutting using the same robotic arm. Okay, so I think the last possible value of endoscopy robots is because of its two arms, it may be able to help us to deal with complications. Obviously, in endoscopy, the two dread complications are bleeding and perforation. So I'm going to just show you a simple experiment on how we use the robotic system to arrest a bleeding vessel. So this is on an animal model again. If you could see that there's a flip chill here using the thing to lift up, okay, the bleeding spot. And then at the same time, the grasping arm will grab hold of the vessel so that you can't stop the vessel from spurting. And then after that, you could use the other arm, which is the cautery arm, to slowly cauterize the vessel. Okay, so the other dread complication in doing a complex procedure, endoscopy procedure, is actually perforation. So again, we use this suturing device, which we just managed to design to be incorporated into the flexible endoscopy robotic system to do simple suturing on a animal model. This is in the rectum. So you can see that we created a perforation in the rectal wall, and following which we put in this robotic suturing system. Okay, so one arm is just a grasper, the other arm is actually a sutures with a needle in. And I just I edited the clip to show the end part of how the suturing was secure and the knot was tied. So essentially, I think you could see the end part. I think we could actually exchange a needle similar to with the V-lock system, and then after that you could tie the knot together and then you cut the knot, similar to what surgeons. So this is really like a surgical suture, unlike a lot of those things you see in the market, which is not based on the suturing method. So this is really based on the suturing method. Okay, then the last one, the last question I'd like to actually try to answer and then share with you is a question I think Yogesh asked me to answer, is how far is this robotic endoscopy from clinical use? So firstly, I think I'd like to just perhaps let the others know that clinical adoption is actually one of the most challenging part of any innovation, because I think we sort of nowadays, it's not too difficult to innovate. It's not too difficult to come up with a idea, and also it's not too difficult to come up with a solution. But I think to take the solution all the way to clinical adoption is actually very difficult, almost impossible. So you got to be a marathon runner in order to achieve that. You got to go through years, maybe 10 years of this running. And like sometimes I tell people, it's not because we are good. It's because by the time we finish a race, we are 90 years old. So we are the only one left still running at the age of 90. So you are comparing with all the 90s in this world. So there are not many people 90s who can still run. That's why you emerge as the only winner. So that is a kind of thing when we look at technology. It's not because we are good, it's because we got the stamina to run all the way when others already dropped out from the race. So this is exactly happens, okay, when we try to do that sort of thing and try to get this particular system all the way to clinical adoption. So I think there are certain challenges, but it's still possible in my mind that we can eventually achieve that. As I mentioned before, we already done those proof of concept, proof of value. And then in order for us to eventually get this endoscope adopted into clinical practice, we do have to do what we call large scales human clinical trials. And then those clinical trials need to answer certain key questions. One is the so-called whether the system is actually safe. Okay, in all counts, you have to stress the system and see really is safe to achieve those indications we mentioned. I think no major adverse events and so forth. And secondly, obviously, I think there must be also so-called performance endpoints for us to achieve. So those are the technical success of the procedure as well as the achievement of certain outcomes. And then finally, I think very importantly for many healthcare systems, I think the technology must show that there is a cost, it is actually cost effective. So I think that's where health technology assessment studies will have to be conducted, okay? So similar to those things I mentioned. So eventually this year, I think we are happy to say that we have taken the system to do this large-scale clinical trials now. Now the regulatory trials are now being performed in one particular indication, which is called colorectal ESD. Okay, so I'm going to show you this video. So far, 15 patients have completed this trial. Since the beginning of this year. It was slightly delayed because of the COVID-19. And all these patients have colorectal tumors, okay? So the tumor could be as far in as a cecum. So I just show you this particular tumor, which is in the proximal transverse colon, very close to the cecum already, and how the latest robotic system managed to do the resect the particular tumor and using the ESD method. As you can appreciate, the left arm is actually a grasping arm, okay? So it's not too dissimilar with the ESD method. So except that I think obviously with the left arm, there's a very good exposure. So you can actually see quite clearly. And also it gives the tension so that you don't really need to cut too much. And then you can just shear through it very quickly. So this is almost unedited, okay? So I think the whole procedure took about 20 minutes unedited. And finally, the tumor is taken out. And then, yeah, so it's completed. So I think repeatedly, I think this has been done and so forth. So finally, I think in terms of health technology assessment, this sort of studies have to be done by benchmarking onto similar procedures. And so in this particular case, in order for flexible robotic system to be adopted, it has to be compared with other existing systems, such as open surgery, laparoscopic surgery, the robotic laparoscopic system, as well as endoscopy system. And then one has to actually do certain trials to look at whether, in terms of cost, in terms of effectiveness, whether this is as good or better than current gold standard method. So finally, I think the end goal, just I think from laparoscopic surgery, we now obviously have the Da Vinci system, which is the robotic laparoscopic system. And we certainly hope that, I think from the endoscopy system, we will soon have this robotic endoscopy system quite soon. So I'm going to conclude my talk and to just summarize a few key points. So number one, I've shown, I think in the 2 studies, that endoscopic robots can actually shorten learning curve in doing complex procedures. And secondly, endoscopy robots can potentially, so we still haven't confirmed truly, we have proof of concept studies, can help endoscopies to deal with complications such as bleeding and perforation effectively. And thirdly, I think to answer Yogesh questions, I think in order for the endoscope, the robotic endoscopy system to be adopted into clinical practice, we do need to demonstrate clinical safety and cost effectiveness. And lastly, I think as far as we know, I think endoscopy robots are now undergoing regulatory trials in patients, okay? I think not just our system, I think one other system is going through now. So I don't think it'll be too far away from clinical use soon. So with that, I think thank you very much for your attention. Happy to answer any questions.
Thank you very much, Professor Lawrence. I have just this actually question. In the endoscopy, we are very flexible. We are running to the ICU. We go to sometimes in the OR. Do you think that this is actually with robotic, we are flexible like as with actually commercial endoscopy?
Yes. So I haven't actually show you the entire setup because it's still going through IP filing now. So I can't show you the outlay, but it's very small. And just to answer Yogesh's question about clinical adoption. So all this consideration, these factors were already factored in at the beginning of the development. Okay, we actually have to show before we file regulatory results that it could be pushed into the endoscopy room. So it's actually pushable. So one system is similar to your endoscopy system, which is the scope. So the scope is plugged onto your endoscopy processor system. And then you have a master console, which is quite small. You can just push in and then sit on the thing. And then the master console, and then the third system is a robotic system, which is again quite small. So all this have to fit into the endoscopy room. It's already factored in. So it can be pushed into ICU to answer your question.
Okay. And you talk about actually endoscopic submucosal dissection on other indications. You think that is like as ERCP or stent in the colon, or this is actually help, or it can actually quickly done by the regular endoscopy? We don't need robotic.
No, currently the system still needs an operator. So still not needs an operator. So it's not something that we can actually do without an operator. It's not smart enough not to be done. But I think to answer your question, I think you are thinking about whether we could use this system to facilitate ERCPs.
Yeah.
So it's not one of our indications yet. Okay, so it's not one of the indications. I think the only challenging part, if you can see ERCP, is cannulation. The rest is not too difficult. So maybe the value is not as great in terms of helping with ERCP. In fact, the value is greater in nodes, we think. In fact, we are already studying the nodes because we already managed to get the suturing already underway. You could see that the suturing is quite mature. So if you want to fully utilize the asset, which is the suturing, then we have to think about how we can go into do nodes very soon, especially those like which involve like full thickness resection. I think a lot of heroes can still do full thickness resection, but I think not everyone in the West can do full thickness resection effectively. So this is one way for us to do full thickness resection. In a way, I think surgeons perform simple surgery.
My last question, actually, do you think that is actually we keep it for more complicated, actually, question like an endoscopic submucosal dissection or big polyp or polyp in the cecum, or we use it for all endoscopy procedures like as so hemostasis or small ulcer and just for injection, which is actually can done in 3 minutes or 4 minutes. And we don't need the robotic. What do you think that is? It could be replaced in the future, all of the endoscopy, according to your imagination or your thinking?
No,
or
I think
for complicated cases.
No, I think it's reserved for complicated cases because I think the way we envisage is that you have one system staying in the endoscopy room.
Yeah.
So I think a person who is trained, because I think no matter what you think about that, I think technology is only enabler. You still need a very, very skillful operator. Just the same as you cannot have too many people. I think you got to have one person trained until he's really good. So I think the simple ones, bread and butter, I think others can do, your colleagues can do. Then maybe one person is similar to EUS. You cannot have everyone doing EUS. So you got one or two very good, well-trained, very skillful. Then the tool becomes very powerful weapons. If they're not trained, even if you have the best tool in the world, I think the results will be different. So we envisage one or two people that if the rest get into trouble with any complicated procedure, any complications like perforation they can't handle. So this guy will be called back and then he just push the thing in and then exchange the thing and just do it. So this is what I think. I think it should be only one system in every endoscopy suite and one or two people who are really well trained to handle everything as if he's a surgeon. He's a savior for the endoscopies. Okay, and other procedure can be reserved. Say you have encountered very complicated polyps, so you obviously you do not do it on the same day. You tell the patient, well, you come back on another day. I think ultimately, from my own perspective, I think we must do no harm, and then we must give the patient the best outcome. So no shame to say that do another day,
No,
and then
sure.
come back when the conditions are optimal.
Yeah, that is actually a regular day we do it. That is
Sure.
not actually shame. That's true.
Yeah.
That's true. Okay. Any other question? So thank you, Professor Lawrence.
Thanks a lot.
For the very
Thanks.
interesting journey in the future.
Sure. Okay. Thanks, everyone.
Okay.
So,
Dr. Yogesh.
okay, bye.
Bye. Thank you.
Okay. Am I online?
Yeah, you are online. Okay.
Okay, thank you much. Thank you, Majin. Thank you, Yogesh. Thank you, Salim. I think this is a wonderful meeting. It's really a great pleasure for me to introduce Professor Dong Guan Xiu. Maybe you don't remember me. I think we went to Korea twice. We saw him Professor Shin in the long old days. We visited the center. He is really the chairman of Gastroenterology, University of Ulsan, South Korea. He was graduated from the prestigious Seoul University College in 1987. Served 3 years in the sanitary center in the army. But his main achievement actually received several awards, including Young Investigator Award from APDW in 1996. And he was main interest in the cholangioscopy in 2002. He's published a book, big book about cholangioscopy. His main field of interest is ERCP, EOS, and cholangioscopy. He created a lot of advanced endoscopy workshops, a lot actually. And he's really a dedicated one man. He served actually as the Secretary General for the World Endoscopy Organization from 2013 to 2017. And he's now the treasurer for the World Endoscopy Organization from 2017 until 20, and chairman for the steering committee for the World Congress of Endoscopy 220 and the Indo 20. He also served as chairman of the educational committee in the Korean Society of Gastroenterology and director of the Gastroenterology Specialty Board in Korean Society of Internal Medicine. He's actually one of the pioneers in the field, and hopefully he's working as active member for a variety of national and international societies, including the World Endoscopy and the Korean Societies, international societies. He's welcome to our group, and I'm very proud that I visited your center before you were that time, and I'm very delighted to hear more about the talk that you will deliver. Thank you very much. Please do.
Thank you very much. It was a really kind introduction, generous introduction. Because I was a little bit worried about connection issues, I already sent my recorded video. So I think AEG Group Flora will play it.
Thank you very much. Thank you very much. It is really nice to be part of this wonderful meeting. Actually, this is my first occasion to deliver a talk which is held in UAE. My special appreciation goes to Dr. Yogesh Shastri for giving me this opportunity. During next 20 minutes, I'm going to cover following areas: ethanol injection for the management of pancreatic solid tumor, EUS-guided RFA for the management of pancreatic solid tumor, and ethanol injection therapy for cystic tumors of the pancreas. The first is ethanol injection for solid tumor. This is 99-year-old gentleman admitted because of recurrent attacks of hypoglycemia. At the time of hypoglycemic attack, the patient's insulin and C-peptide was markedly elevated, suggesting the presence of insulinoma. But the CT scan did not show any identifiable mass. This patient was consulted for EUS examination, so I did linear EUS examination on this case. I checked pancreas body and tail first, but there was no identifiable mass. But in the head of the pancreas, we can see about 1 cm sized hypoechoing mass. I added contrast lens EUS examination, and the sonoview was used for this contrast enhanced EUS. After contrast injection, 15 seconds after, we can see very strong arterial enhancement on the right side. This is typical finding of neuroendocrine tumor, including insulinoma. So based on typical clinical history and biochemical data, and also EUS finding and the contrast-enhanced EUS finding, I thought this lesion was the culprit lesion causing recurrent attacks of hypoglycemia. But the problem was, what kind of treatment should we offer to this case? This is almost 100-year-old gentleman, and the pancreas head resection may not be a good option because of high surgical morbidity, even mortality. Chemotherapy may not be advisable. Observation is not possible because of recurrent collapse. I decided to treat this case by EUS-guided ethanol injection. This is at the time of ethanol injection, 22-gauge needle was inserted into the hypoechoic mass. The bottom half was already ablated, and we are targeting the upper half of the lesion. At what about 0.2 cc ethanol was injected into several parts of the lesion. 3 days after treatment, we repeated contrast-enhanced EUS. Left side is before treatment and the right side is after treatment. If you see the red arrow area, before treatment we can see clearly contrast enhancement, but after treatment that area shows no contrast enhancement at all. This means there is no viable tumor vessel inside. So we confirmed this lesion was ablated effectively. And after this treatment, the patient never had hypoglycemic attack again. This is another case. Actually, this case was a Taiwan Alive case in the year 2012. This CT scan shows enhancing neuroendocrine tumor in the body of the pancreas. For the treatment of this lesion, we used the EUS-guided ethanol injection technique and a linear EUS showing hypoechoic mass in the body of the pancreas, and we inserted a 22-gauge needle, and about 2 cc ethanol was injected into the lesion. This is a CT scan after ethanol injection. Previously, we were able to see enhancing nodule on this area, but now we cannot see clearly the lesion, but there was small inflammatory change near the tumor. This is 6 months after treatment. Now we cannot see any enhancing nodule in the body of the pancreas. It was very effective treatment. This is our Asan Medical Center experience. My colleague Do Hyun Bak reported this result. Ethanol injection was tried in patients with insulinoma and non-functioning neuroendocrine tumor. Included patient was 11 patients, and the number of tumor was 14 tumors. Complete response was observed by single treatment session in 54% of the patients. After multiple treatment session, CR was achieved in 61% of the patients. Adverse event was occurred in 36% of the patients, mostly pancreatitis, and including 1 case of pancreatic duct structure. But majority of the case, the pancreatitis was mild form, effectively managed by conservative treatment. EUS-guided ethanol injection is generally indicated for small, benign tumors, such as insulinoma, neuroendocrine tumor, and solid pseudopapillary neoplasm. If you are interested in this technique, please refer these articles. There are some limitations of ethanol injection. People may assume that if we inject ethanol into the tumor, then the injected ethanol spread out through the tumor spherically or evenly. But the reality can be different. If there is any inhomogeneity of the tissue consistency, then the injected ethanol can be leaked out through the weak plane. This is animal experiment. I injected ethanol into the pig pancreas, and then if there is loose tissue plane, the ethanol is leaking through this plane. It does not spread out evenly inside the tumor. These are current issues of US-guided ethanol injection. The method of injection is not standardized yet, and the amount of agent is not calculated scientifically. It's empirical treatment. And one of the issues is remnant viable tumor. If we inject ethanol into the three-dimensional structure, some areas are ablated effectively, but the other areas, there can be some viable tumor. These are the current issues of before widespread use of ethanol injection. The next area is US-guided RFA for solid tumor. RFA is local ablation modality by delivering energy to target area. It is composed of RF electrode down left side figure and RF generator down right side figure. RF generator supplies RF power and produce voltage difference between active electrode and the reference electrode. RF electrical field oscillate with RF frequency and causes oscillatory movement of ions in the tissue. This movement will create frictional heat, and tissue heating is the main mechanism of RF ablation. Percutaneous RFA has been used in clinical practice for a long period of time and mainly done by interventional radiologists. On the other hand, US-guided RFA is relatively new field. These are current indications of US-guided RFA. Neuroendocrine tumor, solid pseudopapillary neoplasm, pancreatic cancer, and adrenal tumor. Although there can be some controversies, I think the indication can be widened more if we accumulate more data and experience. This is 43-year-old male patient suffering from MEN1. This patient received multiple operations. Distal pancreatectomy due to tail tumor and adrenalectomy due to Cushing syndrome and ependymoma syringomyelia operation, parathyroid operation. And now on this MR image, we can see the newly developed neuroendocrine tumor at the resection margin of the pancreas. The patient refused any more surgery, so we decided to do US-guided RFA. This is US view at the time of RFA. 19-gauge RFA electrode was inserted into the deeper part of the tumor on the right side of the tumor on US screen. We started ablation by applying 50 watts power and 1-point ablation just for 10 seconds. And then after one side ablation, we retracted the electrode to the superficial part and started another ablation. And after this one line ablation, we changed the needle direction to the left side of the tumor and created another ablation. But this is just one plane ablation. After one plane ablation, we removed the needle and tried to find out another plane and repeated the procedure. Left side is MRI image before RFA, and right side is 1 month after RFA. This CT follow-up shows necrotic area inside the tumor. This is 9 months after US-guided RFA. We can see marked decrease of the tumor. On the right side, we cannot identify the tumor anymore. This table shows the summary of our experience. We enrolled 1 insulinoma and 2 SPN and 7 neuroendocrine tumor in our US-guided RFA trial. Among them, 70% of the patients showed complete response, morphologically complete response after US-guided RFA. Complication, there can be some abdominal pain or self-limited pancreatitis, but there was no life-threatening complication. This is pancreatic cancer patient. On this CT image, we can see a large tumor already infiltrating into the surrounding tissue and the post-photomesenteric junction. Since it is initially unresectable, we decided to do EUS-guided RFA plus chemotherapy. We did RFA and combined chemotherapy several sessions. Now we can clearly see the size decrease of original tumor. You want to know more about US-guided RFA for the management of pancreatic cancer? You can refer these articles. These are potential complications of US-guided RFA: pancreatitis, MPD stricture, perforation, bleeding. And when we are doing RFA of the pancreas, we should remember that pancreas is close to many vital organs. Next item is ES-guided ethanol injection for cystic tumors of the pancreas. This video shows the techniques of EUS-guided ablation of pancreatic cystic tumor. If there is any growing cystic tumor in the pancreas, we can use EUS for the delineation of the lesion. Under linear EUS view, we can identify the cyst and inject the needle and aspirate the cystic fluid. After aspiration, we can inject ethanol again and re-aspirate and re-inject. This is called ethanol lavage. After lavage, if it is necessary, we can instillate small amount of paclitaxel inside the tumor. These are ideal indications of cyst ablation. Unilocular or oligolocular cyst, size ranging from 2 cm to 6 cm, and without malignant foci and without clear MPD communication. There are several technical variations. Classic technique is ethanol lavage, but we can modify it as ethanol retention therapy, while we can combine chemotherapeutic agent injection such as paclitaxel injection. This video shows the technique of ethanol lavage. Delineate the cystic tumor on the EUS view and insert the needle and aspirate the cystic fluid. As you see here, if we aspirate the cystic fluid, then the cystic cavity is collapsing and the nearby pancreatic tissue or vessel is getting closer. So need to keep the needle inside the cystic cavity. It is very important. After cystic fluid aspiration, we can inject ethanol into the cystic cavity. Now we can see the cystic cavity size is increasing now. This the amount of ethanol is generally same as the amount of aspirated fluid. After ethanol injection, we can do re-aspiration. Now the cyst is collapsing, and this procedure can be repeated 3 or 4 times. And this technique is called ethanol lavage. Classic ethanol lavage means repeated injection and re-aspiration of fluid. It is generally good for small size, relatively small sized cyst, unilocular or bilocular cyst. We can avoid any leakage of ethanol because there is only one time of needle insertion into the cystic cavity. This is a large cystic tumor in the tail of the pancreas. Upon use, we can see some septations. and the cyst wall is relatively thick. I used 22 gauge needle to aspirate the cystic fluid. This is EUS view. Before needle insertion, you are generally applying Doppler to avoid any intervening vessel. After needle insertion, we aspirated the cystic fluid, and this is the color of aspirate. And then we injected 100% pure ethanol inside the cystic cavity. We can see echogenic jet going inside the cyst. If there is non-communicating locule, we can change the needle direction and puncture that locule and aspirate and inject ethanol. After enough retention time, we did re-aspiration of cystic fluid and then instillated a small amount of paclitaxel. This is variation of ethanol lavage. When the cystic fluid amount is large, we are using ethanol retention therapy instead of ethanol lavage. Ethanol retention therapy can give longer retention time after ethanol injection. We are rotating the patient, supine 5 minutes, left lateral decubitus 5 minutes, prone 5 minutes, and right lateral decubitus 5 minutes after ethanol injection. It can give better contact of ethanol to the lining epithelium. Generally, 1 or 2 rotations are required, and this means 20 to 40 minutes of retention time. It is good for large cysts or multilocular cysts. And when it is necessary, we can combine paclitaxel injection. This slide shows serial changes after 2 sessions of EUS-guided therapy. Initially, it was a very large cystic tumor. 3 years later, it became smaller. After second session of therapy, started to show size decrease again, and 7 years later, the cystic tumor is completely disappeared. We analyzed long-term outcomes after EUS-guided ethanol ablation of pancreatic cystic tumors and reported the result in Endoscopy 2017. A total of 164 cases were ablated, and among them 6 patients lost follow-up. So we analyzed 158 cases. Among them, complete resolution was observed in 72% of the cases, and partial resolution in about 20% of the cases. Persistent cyst was observed in about 8% of the cases. We also analyzed the recurrence rate after initial CR. During median follow-up of 6 years, and some patients received follow-up more than 10 years, the recurrence was observed in only 2 cases. The recurrence rate was 1.7%. So we can say EUS-guided ethanol ablation can be a durable type of therapy for pancreatic cysts. This table summarized the reported literature of cystic tumor ablation. So if you are interested in this technique, please refer these articles. In summary, EUS-guided ablation can be applied for the management of pancreatic, solid tumors, and cystic tumors. For solid tumors, EUS-guided ethanol injection or RFA is commonly done for benign or malignant tumors. For cystic tumors, EUS-guided ethanol lavage or ethanol retention therapy can be used, and if necessary, we can add small amount of chemotherapeutic agents. Ladies and gentlemen, I'd like to conclude my talk with this last slide. EUS-guided ablation therapy can be effective in selected group of patients with acceptable level of post-procedural complication, but further studies are required to increase the efficacy and to avoid complication and for widespread use of this technique. Thank you very much for your kind attention.
Many thanks, Professor Chio. That was a wonderful talk. We have two questions. One from myself, but if you have a hydatid disease, what will happen with the aspiration or the internal injection? One question from the audience about comparative studies between alcohol and radio frequency ablation.
Okay. The first question about hydatid cyst. Unfortunately, in Korea, it's really difficult to see hydatid cyst. But I think if there is no leakage, ethanol may not be harmful to the patient. If he just aspirate the cyst fluid without any leakage and inject ethanol and do some lavage, I think maybe possible type of treatment, but I don't have any data, so I cannot say firmly on this aspect. And secondly, the RFA and alcohol injection for the response rate, it was question from the participant. And above that, there was one more question, alcohol into insulinoma, how much alcohol should we inject? If I answer those two questions, for insulinomas, alcohol injection is a good therapy because insulinoma is generally small size, but because of the functionality, the patient comes to clinician recurrent hypoglycemic attack because of a hypoglycemic attack. So if the tumor size is small, ethanol injection, the amount of ethanol is generally small. We don't need large amount of ethanol injection for insulinoma. And if we inject just small amount of ethanol, then the functionality of insulin secretion easily destroyed. So the patient became asymptomatic. So it can be a good type of therapy. But the issue is, still I'm suspecting there can be some remnant viable tissue, even though it is small. So later there is a risk of recurrence of ethanol injection. So the amount of ethanol is generally, if it is 1 cm size, less than 1 cc or 1.5 cc, just a small amount is good enough. If the tumor is 2 cm, then less than 2 cc or 3 cc, I think that is my usual approach. For RFA and ethanol, I prefer, for solid tumors, I prefer to use RFA because of ethanol injections is not, as I explained during my talk, the injected ethanol may not spread out evenly or spherically inside the tumor. So for the consistent results, I prefer to use RFA.
Okay, thank you.
I have actually two questions. The first question, do you have actually size for the cyst where you decide actually for ablation or injection? The other actually question, which the most complication which you faced during your actual procedures?
Cyst ablation. The size of cyst I targeted is as I mentioned during my talk, I generally target between 2 to 6 cm cysts. It may be MCN, it may be SCN, it may be indeterminate cyst. And locularity-wise, unilocular or oligolocular cystic tumor. And the most serious complication I faced during ethanol ablation, cyst ablation, was main portal vein thrombosis. In one case, the cystic tumor was located very closely to SMV and the portal vein junction area. But at the time of ablation, I did not pay much attention to the proximity. And I did 2 times of therapy. And after that, the patient developed main portal vein thrombosis. So when the cyst is located very close to the big vessel, we need to be very careful.
Okay, thank you. If you have cyst like as 2 centimeter and you actually decide to follow the cyst, if it's actually growing in the cyst, then you decide for ablation, or from the beginning you want to ablate the cyst, or just as following the cyst, if there is 3 centimeter or 4 centimeter, and you go directly with the ablation?
Size is just one aspect we need to see before deciding therapy. 2cm cyst, not all 2cm cyst is same. So we need to apply several techniques to get the better differential diagnosis. Even though it is 2cm, if there is any malignant foci or suspected mural nodule clearly, or if there is clear communication with the main pancreatic duct, I do not target those lesions. If it is benign looking and unilocular or oligolocular without any communication with the main pancreatic duct, yes, we can target it. But generally, I start to target the lesion more than 3 cm. 2 cm, 2.5 cm. If it is benign, I think better to follow those cases and see some period of time how fast it grows. If the growing speed is very slow, then we don't need to touch those lesions.
Many thanks, Professor CEO. I think that was a wonderful talk. And I think we learned a lot.
Thank you very much.
We will move now to Dr. Salim Awad, the expert in the field, and will introduce our colleague from Japan.
Thank you, Dr. Maki. Thank you, Dr. Yogesh, for inviting me. It's a pleasure for me to introduce Professor Takao from Japan. Professor Takao is presently chair of Department of Gastroenterology in the University, Tokyo Medical University. He is graduated from Tokyo Medical University, 1991. He learned pathology and between 1992 and 95. His major is diagnostic and therapeutic endoscopy, in particular pancreatobiliary disease by means of EUS, ERCP, including balloon enteroscopy, assisted ERCP. Until now, he has outstanding endoscopy skill and has published many papers on high impact journals and novels on special technique and outcome. We're very grateful to have you, Professor Takao, in this meeting to listen to your presentation. Thank you.
Thank you very much. Kind introduction, Professor Salim Awad. Hello, everyone. I'm Takao Ito in Tokyo now. I'd like to say thank you very much for the kind invitation for me in this wonderful international webinar. Anyway, so also thank you so much for inviting me, Professor Yogesh. Okay, let's get started. Share my slide. Okay, and let's get started. My topics: lumen approaching metal center in therapeutic endoscopy. You know, the interventional UVS includes a multi-step, namely the puncture, guide wire, tract direction, and stenting. However, you know, the stent are not dedicated stent, but conventional biliary stent usually. Here you can see the several metal stents for interventional US now. Of these stent, the lumen, so-called the lumen approaching stent includes only 2 stents so far. I think true lumen approaching stent is Axios from Boston Scientific or Specials from Teon company. Other short tubular fluid non-fin or with fin type is not really a lumen approaching metal stent. So I mean, I said again, the lumen approaching stent means lumen to lumen. Between the lumen to lumen, the opposite stent. So Axios or Specious is real lumen approaching metal stent, so-called LAMS. That's why interventional US using actually the LAMS stent means like this. Very reliable and very safe stent. So many years ago, 8 years back, I and Dr. Kembimura, who invented this stent, luminosity metal stent, reported the first clinical report on LAMS by for the treatment of gallbladder drainage and pseudocyst drainage. Now, you know, we can use hot lamps, hot actions, the enhanced tip cautery. It's a very nice without any puncture, sometimes so-called one step. That's why now shift to the technique. So there are multiple step of this technique change to the simplistic technique, puncture guide wire and the trough dilation plus stenting using these hot lamps. Two steps, so-called, or one step, freestyle, we call the interventional US, including puncture, trough dilation, and stenting. So in this topic, in this lecture, I intentionally don't discuss. I will not discuss on the merit or demerit, disadvantage or disadvantage of the LAMS. Only I'd like to introduce the application, its application using LAMS technique. So you can see, so there's so far so many applications of this stent. Pancreatic fluid correction, gallbladder, bile duct, liver abscess, bilioma, pelvic abscess, pancreatic duct, GI structure, and gastroenterostomy. So let's see one by one. Pancreatic fluid correction is the most preferable technique using LAMS. Like this, even using a huge one, we can easily treat by only by one LAMS. Let's see a movie. This is a huge one, infected one, and includes a lot of necrotic tissue. So she's my junior. Only by this is the first time of this stent for her. Even first time under supervisor like me, so she got it easily. Placement of this stent. First time, but I didn't see she first time did it. Very nicely placement by herself. So physician control stent deployment system is so nice. Of course, after placement of this stent, if necessary, we can easily perform the endoscopic necrosectomy by this stent. Usually, so we use 20 millimeter in diameter LAMS, but sometimes 15. Only drainage, I think 10 millimeter diameter LAMS is enough. Next, gallbladder. So many years ago, we performed this procedure by using double pigtail plastic stent. However, now the LAMS is a most safe the devices, I think. Let's see, huge gallbladder, descended, enlarged gallbladder with huge stone. So this procedure without any puncture guide wire system, so-called freestyle placement. A lot of the much pass from the LAMS, you can see. So there are so many papers which shows the usefulness of this stent. This is from GATT, or recently this year, drug one study by Professor Anthony. This is a so nice evidence, high-level evidence of this procedure. Of course, Professor Todd Ballon shows in New England Medicine. This is the LAMS, the global US GBD with LAMS is one of option of the non-candidate global drainage. So, of course, if necessary, like endoscopic necrosectomy in the one, if necessary, we can remove the huge stone of the gallbladder like this. In this case, using mechanical resorption under direct vision, crush, and one by one, one piece, two piece, remove. If necessary, again the crush, and finally, whole stone removed. It is a very nice, very comfortable procedure in non-candidate patient for operation. So next topic is a bile duct. Of course, not hepaticogastrostomy, but colorectal duodenostomy. This procedure is comfortable or option. So 2 years back, we published a paper, prospective multi-center study. This is a safe procedure and reliable procedure for colorectal duodenostomy. Let's see a procedure. When we perform this procedure, we sometimes freestyle insertion, freestyle placement. But in case of not so dilated CBD, we use usually the puncture, guide wire, and hot lamps for safe. Usually 8 or 10 millimeter in diameter lamps is preferable. But finally, very nicely placement. As well, if necessary, we perform direct endoscopy procedure. This is at this moment we use slim endoscope, and we remove the small stone in the intrahepatic bile duct one by one using a small basket, and finally whole stone using a EHL or a basket. No residual stone we confirm by cholangioscopy and the direct vision. Next, liver abscess or bieloma. 5 years back, we reported usefulness of the LAMS for the hepatic abscess or infected bieloma, like this schema. Very similar the concept of the drainage of one, like this. So infected bieloma, you can see, and using conventional technique, puncture, guide wire, and the tract dilation, and finally stent. At this moment, not so lumen opposing metal stent. This is a tubular stent. At this moment, unfortunately, they easily move, and 2 years later, 2 years back, 2 days later, they spontaneously dislodgement. That's why. So since then, we use usually the lamps in this like this case. Next, the pelvic abscess. This is a report from the USA, and the huge pelvic abscess. But when using these hot lamps, local vasculature. Looks very difficult, but using these lamps, the complete resolution of the severe abscess achieved. So this is one option because usually the pelvic abscess is much concentrated on the much pass. That's why large bore metal stent and the lumen opposing metal stent is much better. And then the pancreatic duct. Pancreatic duct, I think you know the usually is a very small duct. That's why no indication of this kind of lump. I think so. Basically, I lump the tubular metal stent or even plastic stent. And one paper from USA, you can see the much dilated PD, like Gorbaza. In such cases, I think it is the preferable. It's suitable using lamps drainage. Of course, otherwise very dangerous, or sometimes it causes the unnecessary, unexpected complication like bleeding or migrations, the dislocation. So another two indication, it is very interesting, and maybe in near future a lot of indication. One is the malignant stricture, malignant GI tract stricture. You often encounter this situation, esophageal stricture, malignant esophageal stricture. Sometimes we are afraid of a tubular long esophageal stent because of a migration or dislocation. In this case, small, not so long stricture. That's why this kind of lumen opposing metal stent was used and useful. And another indication, the malignant pyloric stricture. So in case of the short stricture is one of a candidate. Another one is upfront loop stricture. It is also very interesting. The blind loop here and the upfront loop using a large balloon, and the combination of use of large balloon technique and the puncture as a target, the large balloon, and finally place lumen opposing metal stent. Let's see. It is a unique technique. So the puncture to the large balloon, dilated to large balloon, and then finally, in case of this kind of tough stricture, one of option to use a large balloon puncture technique. And finally, they were very successful. Congratulations. So another technique, esophageal jejunostomy, is the complete obstruction. You can see the stricture site, complete obstruction, even though. So the echoendoscope shows relatively nice the lumen. Nice lumen, and then puncture and injection to distend the jejunum, and after enough distension, the hot lamps insertion, and finally recanalization achieved. It is so nice. It is a nice technique. unless patient undertakes operation. So there's no way. You can see a relatively nice summary of this the LAMS, the application for benign GI stricture. Case number not so large, but relatively so nice technical success and the clinical success. Of course, we need a comparison to the surgical reoperation. Other the LAMS application, the paper. You can see the number of the 25 cases are relatively so nice cases. Anyway, technical success is usually 100%, but clinical success is 5 to 6%. Not so high. That's why we need the evaluation. So you can see a very nice movie, but the time is limited. We shortcut in the same way, same system. And so one meta-analysis of the LAMS for benign GI stricture shows the outcome of the clinical success is not so very satisfactory, as I said. That's why we have to evaluate in the near future. LAMS is good or not for treatment of benign GI stricture. Anyway, so let's see. Let's skip. One of the obstruction, choledochal, one of option is a choledochal jejunostomy, like this, using echo endoscope. Complete obstruction case. Fortunately, we can detect the anastomotic site, and using at this moment not hot lamps, so conventional lamps. That's why puncture, guide wire, and the dilation, and then place a metal stent. The final is let's see gastroenterostomy, gastrostomy. First report of this gastrojejunostomy by Professor Bimura. This is a fantastic paper. And also, we published a review of this technique. There are several techniques nowadays in this field. I recommend usually the double balloon occluded the gastroenterostomy using the hot lamps like this. And so you can see already. So I introduced my video so many times in the so many conference. And the two balloon occlude and push the water only between two balloons. And lastly, the freestyle placement. That's it, about 15 minutes from the beginning. This is a very nice CAT scan. And another technique is a US guided direct transenteric the ERCP using lamps like this schema. And sorry, the time is limited. Already, so several cases have been published and very successful. Even this year, 20 cases. Not so many, but I feel the possibility of this lamps for the difficult ERCP cases. So another technique is afferent loop syndrome, like this schema. So very easy to perform the the US guided gastro jejunostomy. Just 5 minutes. no need of a distinction of the jejunum. Very easy. Okay, another technique is also we skip the blind pouch syndrome as well. Okay, so ladies and gentlemen, in my conclusion, the LAMS is a promising device for interventional EOS. There are a lot of clinical use in this stent. And the further application, however, these LAMS will be expanding. We need a check, so day by day. Okay, thank you. Thank you for your kind attention.
Very nice lecture, Professor Itoy.
I cannot see, I cannot hear.
Salem, you have to unmute yourself. Salem, you have to unmute.
Okay.
Professor Itoy, I would like to ask a very common question which has been asked to you a lot of times about your special balloon, the double balloon. Where is it still available? Is it commercially available, or how?
Thanks so much. Unfortunately, not commercially available in basically out of the Japan. However, now we are trying the clinical study on the Ansonitel, the Hong Kong or other Asian countries. So if you can join we are thinking of the multi-center international study. Yeah. Anyway, so after that, we can distribute. We want to distribute my balloon to the world. Yeah.
No, I would like to thank you for this talk and whether there is any comparison between the peristaltic drainage exams in patients with excessive pancreatic cyst accumulation. And the second thing, to minute lamus in patients with SMA syndrome. We have many patients with compression syndrome, for which some of them are back on gastric connection.
So sorry, so I cannot catch up the your voice. Maybe
Salem, can you repeat, Salem? Can't hear you.
The first question is the difference between laparoscopic drainage by surgeon and by our endoscopists using lamas in pancreatic cyst accumulation or post-pancreatic.
Pseudocyst drainage.
Okay. Of course, many years ago, surgical the treatment is our first treatment, first line treatment for the pseudocyst one. However, now the US guided is a most safe and reliable procedure, in particular using this kind of lamps. Yeah.
And the second question is, we have patient with SMA syndrome with obstruction of the between the duodenum and stomach and the duodenum, or the first part or second part of the duodenum, for which they may require surgery. And can we embark on LAMOS doing endoscopically rather than doing surgical gastrojejunostomy?
You mean the gastrojejunostomy for the LAMS?
Yes.
Okay. So, yeah. Some points I agree with you, but so our gastrojejunostomy technique is I think using double barrel is more safe, and it's a good technique. Of course, you mean surgical gastrojejunal?
Yeah, versus endoscopic treatment.
Sonographic.
Endosonography is
endoscopic versus surgical GJ.
Yeah. Surgical
for SMA syndrome.
Yes.
Afferent root syndrome.
Yes.
Yeah. Of course, in case showing the Afran syndrome is usually the terminal stage, end stage of the patients. That's why. So minimum invasive treatment is much better. That's why. So if possible, US guide endoscopic treatment is good for the
Minimally invasive approach.
yeah.
Okay. I would like to thank all the chairpersons and speakers for the nice session and a very good discussion. We'll move on to the last session before the prayers and lunch. It will be chaired by Dr. Philippos Georgopoulos. So Philippos is a dear friend and he is a consultant gastroenterologist and head of gastroenterology at Al Zahra Hospital, Dubai. He's been trained in Athens. He is an accomplished interventional endoscopist with special area of interest in ERCP. And I would hand over to George to take over the proceedings.
Hello, good afternoon, everybody. I'm very happy to be here among all the local and international distinguished guests. Thank you, Dr. Yogesh, for the invitation. I would like straight away to introduce the distinguished speaker, which is Professor Rung Sung. He's a professor at the University of Chulalongkorn in Thailand. Professor Rung Sun, he has done his training, his gastroenterology training in the States, in Louisiana, and he's advanced biliary therapeutic training in Indiana. He has a special interest in ERCP, in general in the therapeutic GI, but he has a special interest and he's an expert in cholangioscopy that he's going to speak about it. Cholangioscopy has become more and more popular even in our region, and we're looking very much forward to listening his talk. Please, Professor.
Good afternoon. Thank you once again for inviting me to this wonderful meeting, and thanks Professor George Philippos for kindly introduce me. It's my pleasure to introduce the next chapter. We know that ERCP has been here for more than 50 years. Actually, I born in when people start doing ERCP, so it's kind of very old procedure. But I think we still have room to go with this cholangioscopy. So I would show some of the trick and tool that I have learned from many of you and share with you today. As you know that the original ERCP that we use for cholangioscopy, we use fiber optic system. So in this way, you can put it in two types. One is fiber optic and the other one is digital or video. Either used as a one doctor, we call single operator cholangioscopy, or dual operator as in the past. But this is probably the fade out quite some, and the system in terms of scope setup. So I would say that one big thing that we have the big challenge is how can we get into the viaduct, because usually being performed by expert if you do what we call direct per oral cholangioscopy. But with this, you have the chance to have the better image enhancement, and also in terms of seeing things nicely and have better channel. So I would say that multi-BB scope and the old system we call the legacy spyglass is probably fading out. But what we're seeing now is more of direct per cholangioscope and this digital spy system. As you can see here, the diameter are quite different, and this is come as a plus if you have the difficulty of going in because of very big scope, but you have better and bigger channel. Regarding the movement, they're usually these days are always four-way movement. So you can can imagine move left or right, up or down, but it's still not that perfect compared to your luminal endoscopy. According to visualization, usually they are excellent, at least to the standard definition level, or even some of them with the new epochs, you can see a full, high definition. And with that, you can see we call image enhancement like NBI or FICE or eye scan, but still challenging in terms of insertion. With the direct per oral cholangioscope, it's quite difficult for you to make a U-turn to get into the viaduct compared to the two-scope system. So in my practice, I would put it as SOC, single operator. In this case, the representative is mainly the spy scope. This one is probably more of nasogastroscope. The spy scope or SOC is the one that have easy for bleed intubation, It usually comes with SD definition and have 1.1 access channel. And the design from or regulation from the manufacturer is for single use. And with this small scope, the minimum CBD diameter for insertion is about 4 millimeter. On the other hand, the direct per-oral cholangioscope with nasogastroscope is more difficult to intubate. And by expert hand, you can reach up to 70%. But I would say from beginner, without any additional device to have like balloon to rope it up, it's probably less than 50%. And also, it usually limits your access to the below the hilum unless you have a very huge and not sharply angulated intrahepatic duct. Of course, it presents you with full HD definition and also contained with bigger channels. So basically, you can put bigger device through this one, including the basket and balloon. And more importantly, for Asian country, for the one with financial constraint, is reusable. And however, it requires the CBD insertion to be bigger than 8 millimeter. And of course, it comes with image enhancement function. Right now, I would say the use of cholangioscopy are limited mainly in these three areas. The biggest one is for the stone management for those with large CBD stone, IHD stone. And second is to diagnose patients with suspicion for biliary malignancy. And lastly, for selective intraductal biliary cannulation, in whom that only cholangioscopy guidance is not enough or not possible. Let's say like to the hilar obstruction or to the cystic duct in the gallbladder. I'll show you the video later. This is the traditional picture of stone fragmentation by basket. With this, you have to have the perfect sedation, like big bile duct, and the stone is not too tightly fit. So you can move around with your basket and then you can capture. But remember that you have to do it under fluoroscopic guidance. So one of the concerns is the exposure to X-ray. Many times it takes you, more than 10 minutes to have the perfect crush like this. And in case you have more than one stone, the procedure could be an hour or even longer. And at the end of the day, you get tired because of it's all requiring mechanical treatment. But this day, I think in our institution, it's probably become easier and not that cumbersome by using this either with EHL probe or laser lithotripsy under cholangioscopy guidance. So I will show our result in those different types of stone. But first of all, let's say that if you encounter with this big stone but have very tapering CBD, the problem is you have to fragment stone small enough to be able to capture those fragments past to this very small passage. So your passage basically has to be smaller than the passage. If you end up with these multiple stone or very huge stone, it will take forever. So this is something that you need to consider, that if you have the help from cholangioscopy with, I think, laser or EHL lithotripsy, it would help you quite tremendously. Yes. And this is the study we published earlier regarding the comparison between the cholangioscopy guided laser lithotripsy treatment versus mechanical lithotripsy treatment. As you can see from here, in these 24 patients per arm, in this mechanical lithotripsy, there were certain patients that we failed because of we don't have enough room to open the basket, or at the end of the session, we cannot complete a clear land of stone because of some big fragmentation still there. On the other hand, we have complete clear land usually in one session in this with cholangioscopy guidance for laser lithotripsy. Interestingly, with the exposure to X-ray, as you can see that because we do not require the X-ray to guide laser lithotripsy, so the exposure become much lower than the patient who underwent mechanical lithotripsy. We talked about exposure not only to the patient, but also to the team, the endoscopist, the nurse, and the assistant. So my next move is on the diagnosis by using cholangioscopy. Usually, it's not straightforward or extremely left or right, malignant or benign. In our region, most common cancer is bile duct cancer, cholangiocarcinoma. It's followed by pancreatic cancer and some other metastatic disease or other compression from the lymph node. Benign, usually we have history of surgery like cholecystectomy or bile duct surgery. But some other condition like IgG4 related or parasite or patient with portal hypertension is something that you usually rely your diagnosis based on the preceding history. But when it comes to the patient with obstructive jaundice without having definite history or the risk or no mass that you see by imaging, what should we do? Sometimes many of them underwent ERCP and turned out to be that the result of tissue became negative. In this case, we usually call as indeterminate stricture, as you can see from here. So I would say first, patient with suspected malignant stricture, when we have malignant clue like obvious mass on cross-sectional imaging, or we have elevation of CA19-9 or have symptom, and no other history of benign etiology like inflammation, like pancreatitis, we usually put them for ERCP and then perform tissue acquisition either with biopsy or with brushing, or you can combine. But with this, I can show you the result that if it's negative, we call as indeterminate biliary stricture here. So what we can use this one to improve, of course, if we go indirectly and we can target the area that we suspected for cancer, we can do precise or targeted biopsy. So this came out in very early of 1989, what they call tumor vessel. It's just like gastric cancer or other type of GI cancer you have, we call abnormal neovascularization that's representing usually either neoplasm or inflammation. On top of that, Professor Dong Wan-so showed the other tumor feature, and he called as a 3 type of potentially adenocarcinoma as nodular, surface, infiltrative lesion, or papillary projection. So when you look at detail with better, the previous one was more on fiber optic version. This is a digital version. You can see quite clearly with tumor vessel here. And I would say all of these other features with papillary projection, infiltrative lesion, or even nodule, they all contain tumor vessel. So with this, we would advocate they are all representing tumor or even something that's specifically to like cholangiocarcinoma. And you look at this cartoon to demonstrate better clarity of pattern, either flat pattern, polypoid pattern, oscillatory pattern, or honeycomb pattern. So with this, if you put all these criteria together, the sensitivity came up as 96% with a specificity of 92%, with PPV of 93%, with NPV of 96%. Of course, by expert, your capture value, we have very good agreement of more than 80%, but it's not too bad with the non-expert, 65% to 82%. So let me show you the first example of quite typical, the extrahepatic cholangiocarcinoma in this patient. You go in, you see, just like polypoid appearance with some, see they just passed some tumor vessel area. With this, you can use your, cholangioscope and, precisely target to the area that you want to. Actually, these are something that we think is considered as potentially represent the, the cancer. So another case also came with obstructive jaundice, as you can see here, with some, feeling defect in the bile duct. And you went in and you see that this is polypoid and nodular looking kind of things. This is something that you can do biopsy from anywhere. And with this, this bite, this is a spy bite. After a few bites, it came out to be as IPNB, as the intraductal papillary mucinous tumor. Next one is patient, again, obstructive jaundice with dark tumor. You go in with some bleeding like hemophilia, and see that's a cystic duct on the right side. We talk about that later. And again, you perform the targeted biopsy, and after a few bites, you can see some oozing or bleeding, but usually these spontaneously stop, and then at the end, when you see the histology, it's turned out to be as the invasion of hepatocellular carcinoma confirmed by ClipCam-3. Another one, dark tumor, patient came with obstructive jaundice with bleeding, and you do biopsy and turned out to be metastatic melanoma in this patient. Next one, they all have obstructive jaundice, I'm telling you. You go in to see that's like a mass inside, confirmed by cholangiogram. There's a feeding defect like a golf ball inside the bile duct, as you can see here. And it's more like subepithelial lesion with this, again, with a small biopsy faucet. But because we think it's underneath the biliary epithelium, we do bite-on-bite technique, and it turned out to be gist of the bile duct. So I think this day we do much better in terms of the the biopsy. But the original paper based on more fiber optic cholangioscope showing that with these biopsy, the sensitivity was about 60%, and especially, of course, is very high, 98% to 100%. But our latest analysis under submission showing that the sensitivity with the new digital or the video cholangioscope became much better, up to 80%. Another thing I mentioned earlier is visual impression. From those four criteria, usually the sensitivity is better than the biopsy. However, as you know, that there's some the mixture of inflammation, or what we call inflammatory stricture. The specific could drop to 83% here. So my next move is on the drainage. As you know, that in the patient with acute cholecystitis who is very sick, they may not fit to go for cholecystectomy in that admission, but patient usually require certain type of drainage, and generally they require percutaneous drainage. But as in endoscopy, we can offer them in two options. As Professor Itoye has alluded earlier, is US guided transmural drainage with lamps. So I would talk about the other one. The problem with lamps, certain surgeons may concern about future surgery. If patient condition become better, they fit to surgery, but when they perform surgery, they may encounter adhesion, and they also have to close fistula that we create between duodenum and gallbladder. So to preserve the anatomical structure, we recommend to put the plastic stent through the papilla and go to the cystic duct and into the gallbladder. Although it doesn't last long, it is long enough to leave the patient without having another attack until elective surgery, usually about 3 months. But from that, the things that to be able to go to the cystic duct, sometime under cholangiographic guidance, it may not be enough. So you better see the cystic duct, because as you can see in this picture, very tiny, or we call even slit lamp of cystic duct orifice here. It's not possible at all to go in under just this cholangiogram. So we would say that cholangioscopy could help for cystic duct cannulation. I show you this one of our video that we have difficulty to go in. You see that right side is CBD, left side is the cystic duct. It's wide open, but sometimes because of the location, if the cystic duct opening is on middle side, it's not quite easy to manipulate with the cholangiogram alone. So cystic duct cannulation under cholangioscopy is very helpful. In this situation, I would show you that the problem that the cystic duct is not straightforward. So it takes some time, and many times the cholangioscope can use as the anchor to strip your distal system and maintain and manipulate the guide wire. And even here, we suspect this could be some adhesion, because in our experience that as soon as you pull back your system catheter or cholangioscope, usually just like you performing colonoscopy and you stretch out the sigmoid loop, but this one is still fixed as the alpha loop over there. We have tried to go in and out many times. In this figure, in this patient is still not unlooping. So at the end, we decide to put this stent, and we believe that with this stiffer and thicker stent, usually the stent we recommend is 7 French, and the length is very fixed to 15 cm that can do all. And then you can see the flip of the cystic duct under the stent pushing forward, and with this you can drain the gallbladder nicely. So technically, we recommend 025 guide wire. Usually, is preferred stiff guide wire like VC glide, but jack wire sometimes can do. But if you fail, I would recommend the stiff one. And in this situation, if we fail, we can do with cholangioscopy. In our early series submitted earlier, but I think we have reported in GIE this year, we've got about more than 100 patients. The complication is usually related to ERCP, like pancreatitis, and some of them have perforation of guide wire, but actually there's no requirement of surgery. And we probably add about 10, this led to 20% of success rate in those who fail the cholangiographic guidance with the scope guidance. Result to fail, there are many, but usually because of difficulty of the takeoff or completely obstructed cystic duct. So I think this comes to the end of my last slide. In summary, ladies and gentlemen, I would say at least there are 3 areas that we touch on and make use of cholangioscopy. First, of course, is cracking difficult bili stone, either CBD stone or even intrahepatic duct stone by EHL probe or laser. Second, in those with indeterminate bili stricture, I would say cholangioscopy could help you for visual impression and to do targeted biopsy. Thirdly, to have selective segmental bili cannulation in those who have difficulty to do cannulation under cholangiogram, like intrahepatic duct or cystic duct. And lastly, this is my dream future. If we can have a scope that have bigger channel, we can put the device and we see inside like early neoplasm, like patient with polyp in the colon or early gastric cancer, we can perform either EMR or ESD in the bile ducts. That's my dream. Thank you for your kind attention. I'm happy to answer all questions.
Thank you very much, Professor Rungsam. Thank you very much for the excellent talk. I don't know if we have enough time for one question. Anybody that would like to ask a
one question?
Sure,
should be okay.
Yep. If there is no any question, I would like to ask Professor Rungsam, what do you think that's going to be the learning curve threshold for somebody who is involved in the RCP in order to feel comfortable with the cholangioscopy? Because the truth is that it has become more and more popular in our region as well. There are a few centers that have started doing it. We still work 2 doctors. We don't have your expertise to be one who's going to operate both the scope and the cholangioscope. But what do you think is going to be the threshold?
Well, right now we have some information because we have used it quite often. And from the trainee side, after they're able to do, the successful cannulation, we allow them to do cholangioscopy. And with this, we ask them to start with diagnostic things first, like cannulation to the cystic duct or intrahepatic duct, or even do biopsy. But for lithotripsy, usually later on in their final year as a 3rd-year fellow, we allow them to do that. So they are able to expose to this, cholangioscopy. It's not something that you have to wait until you become the attending.
What about also the pancreatic stones? We come across sometimes patients that they have chronic pancreatitis with large pancreatic stones, quite dilated PD. So what about the use in combination with lithotripsy? Would you go straight away for a lithotripsy?
Well, I tell you what, the pancreatic stone is somewhat harder than CBD stone. It's possible to crack, but usually the power setting and time you need is probably more difficult, but it's still possible. And the other thing I concern is the water irrigation and the pain from the water irrigation. And you have to make sure that you have enough water, because otherwise the heat that generates from dry the laser will cause more pancreatitis, but it is possible.
So you're going to go for extracorporeal shockwave lithotripsy first, and whatever.
I would prefer the shockwave is probably the better one, because another thing is we can do only the stone that near the head of the pancreas. The one that deeper in the tail, if you have stricture, it's still difficult to go. We have done with the US guy that coming from behind and try to break stone in the body and tail, but still, I would say that is more of experiment. It's not something quite standard yet.
For the patients that they have a distal CBD stricture and the prestenotic dilatation with big stones, after breaking the stones with laser and cholangioscopy, would you attempt a big dilatation of the stricture part in order to take the fragments out?
I would do the opposite. I would treat the stricture first. Otherwise, you end up with having stone stuck and stone reform again. So as soon as you able to open up the stricture, usually we put the fully coverment stent, sometimes lamps, once in a while, to make the opening big enough, and then we treat the stone. If we fail, sometimes we perform CDS and hit the stone from the stoma.
Right. Any other questions? Anybody else?
I think it's time for prayers. So I think we'll end this session. And thank you, the chairperson, Dr. George and Rung Sung, for your excellent contribution. Thank you both. And we'll break for a quick lunch and we'll assemble for Sham's lecture at within half an hour, 45 minutes. So 13:10 UAE time, Sham will be logging in and he will give his disposition. So thank you again, and a good prayer and good lunch. A light lunch so that we don't sleep in the session after it.
Thank you.